here at the 29th Annual POCS Conference Redefy 2021, and we welcome you to the Surgical Video Virtual Workshop. So we welcome to the inauguration and the welcome ceremony for this wonderful conference. The conveners of the session would be Dr. Milind Dugad and Dr. Chaitanya Ganapule sir. And Dr. Rahul Argade sir will be the session coordinator.
Should we start?
Yes, sir. Yes, sir, you can start.
Are we done with the inauguration videos now?
Yes.
Good afternoon and good evening to everyone. I am Dr. Harshad Parasnis, the President of Pune Obstetrics Gynaecological Society. On behalf of POGS, I welcome you all to today's workshop of our 29th annual conference, Re-Edify. Re-Edify signals reconstruction or rebuilding after the destruction. For nearly one year, all of us have gone into hibernation, have actually been sitting home, and now is the time then when the corona pandemic is on the ebb. That's how we feel as of now. We wanted to actually go back to the physical format of having a conference, and that is why we said that we would now have a conference, Re-Edify, and that was the reason. I welcome all of you all from the embryology workshop, from the surgical videos workshop, from the CTG workshop, and the fetal medicine workshop. At the same time, I would also thank and congratulate Dr. Leena Patankar and Dr. Ashwini Kai for organizing, being the convener of the embryology workshop, for Dr. Milind Dugad, Dr. Chaitanya Ganapule, and Dr. Rahul Argade as conveners for the surgical videos workshop, and Dr. Prakash Kothave and Dr. Santosh Kirloskar for being the conveners of the CTG workshop. In the CTG workshop, I must extend my warm welcome to Fernandez Hospital, along with whom we will be doing the CTG workshop, and here special mention must be made of Dr. Anisha Gala, who has been instrumental in actually formulating this workshop and taking it ahead. In the fetal medicine workshop, I must welcome Dr. Girija Wagh and Dr. Archana Punglia, who would be doing the fetal medicine workshop along with the Society of Fetal Medicine. Here again, warm welcome to Dr. TLN Praveen, who is the president of the SFM Society, that is Society of Fetal Medicine. I extend my warm welcome to all the members, for all these members of the Fetal Medicine Society from Fernandez Hospital, and all the delegates who are actually logged in at this hour to hear on these various topics. We are having a combined inauguration of all these 4 workshops together in order not to waste any further time. So I now declare these workshops to be inaugurated, and I would now like all of you all to go ahead with your own workshops in each of the workshops that you have. A warm welcome to the delegates. Tomorrow also on 6th and on 7th, we will be having the program which will be relayed to you. There are panel discussions. There are going to be an inauguration ceremony in which we have Dr. Alpesh Gandhi, President of FOXI, who will be there in this program, along with Dr. Nozer Sherier, the past Secretary General of FOXI, and Dr. Kaizad Damania. We will also have keynote addresses by Dr. Deepak Kirpekar, eminent urologist from Pune, along with Dr. Parag Beniwale, who is the ICOG secretary, Dr. Sanjay Gupte, who has been the past president of FOXY, and Dr. Bharti Dore Patil, along with Dr. Shailesh Puntambekar. So we have a big list of keynote addresses that would be relayed tomorrow and day after tomorrow. So I would again welcome all of you all to join not only today but also tomorrow and day after. We have a very good audience. We have crossed more than 2,000, and so welcome all of you all, and let us begin with our workshops. Chaitanya, you may start with this workshop. Thank you, Sneha.
Yes,
you can ask.
To the 29th Annual POGS Conference, Re-Edify 2021 at Virtual Fetal Medicine Workshop. So ladies and gentlemen, let me take the honor to invite our conveners, Dr. Girija Wagh and Dr. Archana Pungalia. Welcome, madam. To begin with the first session of the day, I would like to invite our first speaker, Dr. Bhela Bhatt, who will be presenting their talk on how to read double and quad markers. Dr. Bhela, I would request you to please unmute your lines and turn on your video, please.
It is on.
All right. Over to you, madam.
Okay, can I share my screen?
Yeah. Yes, ma'am. Ma'am, put it on a slideshow mode.
Yeah, I'll do that. Okay. Are my slides seen now?
Yes, ma'am. Please go ahead.
First of all, at the outset, I would like to thank Pune OG Society, the president of POGS, Dr. Harshad Parasnis, and secretary Dr. Ashwini Kale, for giving me this opportunity to be part of this wonderful fetal medicine workshop in the conference, which is the theme of Re-Edify. Well, the topic given to me is also very interesting as to how to read double and quad reports. And we have various questions related to this topic. And I'll also try and, as Dr. Harshad mentioned, that we are trying to rebuild and reconstruct in this corona pandemic. So let's try and rebuild some of our ideas related to this double and quad marker report. Now, everybody knows as to what is double marker and what is quad marker. Double marker is done in the first trimester between 11 to 14 weeks and comprise of beta HCG and PEPE, whereas quad marker is done between 15 and to 20 weeks, that is second trimester, and includes beta HCG, alpha fetoprotein, unconjugated estriol, and inhibin A. Now we know that all these biochemical markers are a very good friend of ours in this journey of trying to help our pregnant patients, because along with ultrasound, they throw a lot of light on many maternal as well as fetal complications. So I always feel that all these markers, whether it's beta HCG, PEPE, alpha fetoprotein, estriol, inhibin A, or placental growth factor, which is not part of double or quad marker, but is a very, very important marker. These are all like a different arms of the octopus, and together they give a face to pregnancy. So let's see what all information these markers are going to give us. Now, out of all these markers, some of the markers are placental products. And which are they? PEPE, beta HCG, placental growth factor, and inhibin A. Whereas alpha fetoprotein and unconjugated estriol are fetal products. Now, we know that the most important function of these markers, both double as well as quad marker, is to try and find out the risk calculation for aneuploidy. But do they give us any other extra information? Well, the answer is yes. It gives us a whole lot of extra information apart from just risk calculation for aneuploidy. And that is information regarding possibility of genetic syndromes, neural tube defects, placental dysfunction leading to preeclampsia, fetal growth restrictions, stillbirth, possibility of placenta accreta spectrum, accidental hemorrhage, and preterm delivery. So I'll try and cover this throughout my talk. So let's start first with the aneuploidy screening. Now, double marker, which is done at 11 to 14 weeks for risk assessment for aneuploidy, we must first know about the sensitivity of it. Why? Because a lone double marker has sensitivity of just 60% as far as risk calculation for aneuploidy is concerned, and therefore we must always combine it with nuchal scan. We never do double marker alone at 11 to 14 weeks. We always have to combine it with the nuchal scan and various markers on ultrasound, so that a combination of double marker and nuchal scan gives us a sensitivity of 90% as far as risk calculation for aneuploidy is concerned. So first message is never do double marker alone, always go for combined risk. Now, again, when you read a report of double marker or quad marker, what is most important is to look at the MOM or multiple of median. Why? Because all of us have habit of going to the last page and looking at the risk. What is the baseline risk? What is the final risk? And whether it is low risk or high risk, and we counsel the patient. No. Things are not right that way, because we are supposed to look at the MOMs, which will give us the idea. Just based on MOM, you can make out whether the patient is at higher risk for trisomy 21, 18, 13 or other chromosomal problems. Because in trisomy 21, the beta HCG MM are close to 2, that is almost double, whereas for Pepe it is almost half, that is 0.5. Whereas in trisomy 18, both beta HCG and Pepe are on lower side, and again in trisomy 13, both Pepe as well as beta HCG will be on the lower side. Whereas in Turner's, beta HCG is not much affected, but the Pepe would be on lower side. Whereas in case of triploidy, we see that in diandric triploidy, beta HCG is substantially high. So just by looking at your MOMs, you will get a whole lot of information. So here comes the $1 million question. What all do you look at when you look at the combined test result? I have specifically mentioned the word combined test results because we never do double marker alone. So it is always combined with the nuchal scan. So first of all, we would look at the maternal age with subgestation, anti-centiles, and then beta HCG and Pepe mom. And then we must ask a question as to what has made the risk high. If suppose it is high, whether it's the baseline age risk which is high, which is making the result high, or it is the anti-centile which is more than 95th centile which is making it a high risk, or it is the beta HCG and Pepe MOM which is making the risk high. Just to give you an example, I am showing you a report of my combined test, that is nuchal scan plus double marker, in which first of all we try and look at the age of mother based on the birth date of mother, look at the LMP and the appropriate LMP and the appropriate gestation age, the CRL, the nuchal translucency centiles, and then look at the MOMs of beta HCG and Pepe. Here, how, as you can see, in the nuchal translucency also, the centiles are more than 95th centile, and in beta HCG you can see that it is close to 2.3, that is more around 2 MOM, and Pepe is around 0.5, and that is why the risk of trisomy 21 has come as high risk. Baseline risk is just 1 in 316, which has come as 1 in 7. So before you jump to look at the adjusted risk or the final risk, if you look at all these points, you yourself will come to know that the risk for trisomy 21 is going to be high. So this is how we read a combined test result. Now, whenever there is a low Pepe, as I said, we always have to look at the MOM. So if you feel that the MOM of Pepe are low, 0.5 is less, right? Half the normal 1 MOM. So Whenever there is low PAPA, you have to look at the uterine artery Doppler, which is always done nowadays with nuchal scan, because low PAPA is also a marker for placental insufficiency, and therefore we must have a look at whether uterine artery Doppler is more than 95th centile, because then we have to keep placental insufficiency also in mind. Again, whenever if you find in the report, suppose the beta HCG is high, as in this report again it is 2.3, so it is high, more than 2 MOM. So you must have a checklist for it. First of all, have you given beta HCG injection? These days in so many patients for support obstetricians are giving HCG injection weekly. So if it has been given in last 1 week, then it is likely that the report will be high. So never ever collect a double marker report if you have given HCG in last 1 week. Wait for at least a week. Second thing, sample collection and transport has to be proper, because high temperature will alter your biochemistry. Look at the placental pathology, whether there is any partial molar pregnancy on ultrasonography. Again, triploidy, Turner syndrome, all these are going to keep your make your beta HCG high. So we have to have a checklist for all this. And this is again a very, very important slide, because interpretation of results of these biochemical markers is based on various factors like age, ethnicity, race, gestational week, weight, singleton or multiple gestation, diabetes mellitus, smoker, or IVF. And therefore, you have to choose a lab which takes into account all these factors and gives you the result. And therefore, every machine and reagent matters, all these maternal factors matters. And one very important factor is also that the lab must be auditing all the reports every year, because then only your report is going to be authentic and reliable. So it's your responsibility to look at it that you are using a proper lab for these reports. Now, this is a very good study which in 2015, which showed that even gestational diabetes or diabetes mellitus, insulin dependent, non-insulin dependent, also affects our PAPA and beta HCG markers. And it was found that correction of PAPA is required in case your patient is insulin dependent diabetes mellitus. So I would just like to give you one example of a patient. This patient came to me, 26 years old, who was insulin dependent diabetes mellitus. At 12 weeks, 2 days, she was already referred to me for invasive testing, that is chorion villus sampling, because on her biochemistry, the risk for trisomy 18 was very high. Okay, so when I tried to look at the report, I could go and see that the PAPA and beta HCG MOM so very low. Look at the PAPA, it is just 0.16, and that was the reason why risk for trisomy 18 had come as 1 in 24. Now, when I again went back and looked at the history which was mentioned in the report, there under the heading of insulin dependent diabetes mellitus, it was written no. So though the patient was insulin dependent diabetes mellitus, the lab was not conveyed that she is insulin dependent diabetes mellitus, and so the correction for IDDM was not done. So by just correcting it, by just giving this information to the lab that patient is diabetes mellitus, type 1 insulin dependent diabetes mellitus, look at the risk. It changed from 1 in 24 to 1 in 2,432. So now the patient is in low risk, and therefore from this is the baseline risk and this is the adjusted. So from 1 in 24 it has come down to 1 in 284. So the patient who required invasive testing because of high risk is now into intermediate risk, right? So that is the impact of history and all the maternal demographic factors that you must provide to your lab. So learning point is history is very, very crucial before you order your double or quad marker, and please provide it to the lab. Now, this is another case in which double marker was already done, and the patient, it was showing high risk for trisomy 18 and 13 and was referred for nuchal scan to me. Now, when I put the probe, this was the high risk. I mean, the report was showing that the risk for trisomy And the MOMs of both PAPE and beta HCG were very, very low, 0.04 for PAPE, and for beta HCG it was 0.47. And that was the reason why the risk for trisomy 18-13 was more than 1 in 50. But when I put the probe, the ultrasound showed IUFD. So what is the learning point here? Well, always do a nuchal scan before double marker. Let your nuchal scan be primary screening test. There are lots of advantage of doing nuchal scan first, because if there is some structural anomaly, if there is some marker, if your nuchal translucency is more than 99 centile, then you are not going to do your double marker. Then you are straight away going to advise the patient for invasive. Patient is going to save money on that. So, and in such cases of IUFD, of course, the patient doesn't waste the money on double marker, because your nuchal scan will give all required information. Now, a very important and interesting part of this biochemistry is there is a significant overlap between markers of aneuploidy and markers of poor placental function, and therefore we have to be very wise in differentiating between two of them. Now, what are the markers of placental insufficiency or poor obstetric outcome at first trimester? Well, your beta HCG is going to be more than 3 MOM, PAPE less than 0.5 MOM. Now, alone, if you see, these are also markers of trisomy 21, right? But they are also markers of placental insufficiency. And as I said, PLGF, which is very, very important marker, less than 0.5 MOM. And again, alpha fetoprotein, even at first trimester, when it is more than 2 MOM, will be a marker for poor obstetric outcome, about which I'm going to just talk in short in later part of my talk. So all these markers tell us that there is higher chance of fetal growth restriction, preeclampsia, placental insufficiency, and placental abruption. Now, again, our million-dollar question. So whenever you look at your combined test result, you look at all these factors, ask yourself a question: what has made your baseline risk high? Whether it is the anti-centile, that is nuchal scan, that has made the risk high, or your biochemistry, that is beta HCG and PAPE MOM, that has made the risk high. Suppose the PAPE is on lower side, it will show high risk for trisomies, and it has shown a high risk for trisomies. Then you go for invasive test, which may come as normal, but then there may be severe fetal growth restriction, and in some cases we have seen IUFD also at 18 to 20 weeks. So what does that tell us? That whenever there is low PAPE, you have to be extremely careful in your follow-up of these pregnancies. And sometimes vice versa can also occur. Despite normal biochemical marker risk on combined test, at 18 weeks, some of the markers which were subtle may be picked up, like AVSD or clenched fist, which are the markers of trisomy 18, may evolve. So only thing, most important thing is, these are all screening tests and not diagnostic tests. So counseling, pre-test and post-test counseling is extremely important to tell us our patient that these are just screening tests, and we are not going to diagnose things based on this. We'll just be able to segregate a low risk from high risk population. So a close follow-up is must in every patient. Now let's have a look at the second trimester marker or quad marker, which is done between 15 to 20 weeks, and we know it includes beta HCG, alpha fetoprotein, unconjugated estradiol, and inhibin A. Now, as far as trisomy 21 is concerned, the fetal products are reduced, that is alpha fetoprotein and unconjugated estradiol, and therefore placenta tries to overcompensate for those that loss, leading to increased beta HCG and inhibin A. So that if you want to interpret your quad test, trisomy 21 we have already discussed, and in trisomy 18, all the markers are going to be low, whereas in 13, some of the markers beta HCG and estradiol may not be affected, whereas alpha fetoprotein is going to be on higher side. Now, again, we have seen that double marker gives us lot more information. So does quad marker in second trimester also gives us some bonus, some other extra additional information? Well, yes. A positive test means having a high risk for chromosomal abnormalities, as well as neural tube defects, gastroschisis, omphalocele, preeclampsia, fetal growth restriction, and preterm delivery, which is based on your high alpha fetoprotein. Whereas, of course, fetal death, these biochemical markers are going to be low, and it also throws some light on genetic syndromes. Now, as far as genetic syndromes are concerned, this was again a very good paper, recent paper of 2020, which showed that it gives a lot more information in addition to just aneuploidy screening. And this is something additional, that high HCG at quad marker can also give you some risk assessment for gestational diabetes mellitus, and a combination of high HCG with low alpha fetoprotein can also give you indication for macrosomia in later part of pregnancy. I'm sure many more studies are still required so that they become a proper risk markers, but now we know that we have a lot more to find out from these markers than just aneuploidy screening. And as far as the unconjugated estriol is concerned, now when there is very low level of this unconjugated estriol level, less than 0.15 mom, then it is associated with many of the genetic syndromes. That is Smith-Lemli-Opitz syndrome, X-linked ichthyosis, placental sulfatase deficiency, aromatase deficiency, and many more genetic syndromes. And therefore, when there is extremely low levels of this unconjugated estriol, a genetic counselor have a look at your sonography, whether there is any marker of these genetic syndromes on sonography, and also have a consultation with your geneticist so that we can try and investigate and find out whether there is any such cause. Again, alpha fetoprotein of your quad marker is a very, very important marker, because it just doesn't tell us about the Down syndrome, in which the level of AFP is actually reduced. But when there is unexplained elevated level of alpha fetoprotein in second and third trimester, if the ultrasonography is showing placenta previa, then in combination with elevated level of AFP, it may indicate chances of placenta accreta, increta, and percreta. And we all know how important it is to predict this, because these are the patients then we'll have a close follow-up, subject them to MRI, and we'll try and plan pregnancy in a tertiary center. So the idea is, when you get a screen positive report, see, quadruple marker is screen positive is very confusing for many of us. Well, whenever you see a screen positive report, quadruple marker also, you advise invasive testing. No, that's not true. You must first have a look at it, whether it is screen positive for aneuploidy or for neural tube defect, because if the alpha fetoprotein is high, it is going to give you high risk for neural tube defect and not aneuploidy. Only if it is showing the high risk for aneuploidy, you have to subject the patient for amniocentesis. But if it is showing high risk for neural tube defect, then it is not an indication for amniocentesis, but you must subject that patient for good structural anomaly scan, look at the placental location, and watch for growth if everything else is ruled out, because many patients of fetal growth restriction will have very high level of alpha fetoprotein. Well, this is just one slide that I've included. I know I'm not supposed to even speak about triple marker because it is obsolete. But then we still see here and there some reports of triple marker, and that therefore I want to give this very clear-cut message. Please do not go for triple marker, because we have a better second trimester screening test, that is quad marker, with a higher sensitivity of 75%. Now, this is a very important aspect when we try and look at these biochemical markers. As I said in the beginning only, that I'm going to talk about just double marker and quad marker, but I cannot talk about just biochemical markers, because we are looking at the pregnancy as a whole, and we are trying to help our gravid patients as much as possible, try and predict things early at first trimester scan, so that we can prevent so many complications or manage them well. So rather than just having a look at the biochemical markers, you must also include uterine artery Doppler, look at the placental morphology, the liquor, apart from your fetal structures and markers, so that you get a whole overall picture of the pregnancy, and then try and manage your pregnancy. And it will definitely be able to help this patient, because very high uterine artery PI, more than 95th centile, tells us about the possibility of fetal growth restriction and preeclampsia, and therefore it is a very essential part of our second trimester as anomaly scan. Now, do I have some time so that I can just go through my next few slides, chairpersons?
Ma'am, we are already delayed.
Okay, because I have some, okay, so I'll just try and cut it short. As far just one little mark about the EFTS or the enhanced post trimester test. Why this is very important? Because apart from our beta hydrogen pepe, if you include this alpha fetoprotein and placental growth factor, then placental growth factor will add the risk assessment for preeclampsia, and alpha fetoprotein is going to tell us about the fetal growth restriction. So right at 11 to 13 weeks, you will come to know as to which patient is high risk for fetal growth restriction, preeclampsia, and will also through alpha fetoprotein come to know possibility of open neural tube defect, gastrocysts, and many more fetal structural anomalies. So many centers have nowadays tried to include first trimester quad marker rather than double marker, because it adds to the information and helps in managing our patient better. I'm skipping all these slides because of the want of time. So just to conclude, the points to remember are: choose the right screening test at right time. We know that the combined test is the best screening test with highest sensitivity for general population at 11 to 14 weeks. Know the sensitivity of each test. Counseling, pre-test and post-test is mainstay of any screening test. Low risk does not mean no risk. High risk does not mean presence of a disorder. And discuss what is to be done once the result is in our hand. And document what you offer to the patient. And always keep the option of no screening open if at all patient doesn't want to go for screening after your counseling. Thanks for patient hearing. Thank you.
Thank you so much, Dr. Bela, for the wonderful talk. Moving on to the next session, I would now like to invite Dr. Vivek Kashyap to present their talk on decoding Doppler in FGR. Dr. Vivek, I would request you to please unmute your line and turn on the video, please.
Yes, can you see my slides, please?
Yes, sir. Over to you, Dr. Vivek.
Thank you so much. And before we really start my talk, I must congratulate Dr. Harsha, Dr. Ashwini Kale, Dr. Chaitanya for putting together this fabulous program. And my sincere thanks to Dr. Girija Wag, Dr. Archana and team for making me part of this workshop. So my job to talk about decoding Doppler in FGR. Time 30 minutes. I have to pack 3 different topics into one. Why 3? First of all, we have to know what is FGR. Second, we have to see what is Doppler, brief things about all of that. And third, what is the role of Doppler in FGR? That is huge. But then let us see how we manage. So once we start talking about decoding Doppler, we know first of all definition of fetal growth restrictions. Is it low birth weight, less 1500 grams or less? Is it very low birth weight? What exactly is a fetal growth restriction? And there's been a lot of studies over the decades. And or else, is it abdominal perimetry, which is less than 3rd centile, 5th centile, 10th centile on standard growth charts? Or is it no increase in abdominal perimetry or head perimetry on 2 scans, which are 2 weeks apart? And things like that. So there have been a lot of definitions over the years, but some of them have stood the test of time. Some of them are the birth weight, which is less than 10th centile, or the severe FGR is birth weight less than 3rd centile, or else the expected fetal weight, and so on and so forth. So a growth restricted fetus has also come back with a renewed interest. And the reason is that a simple definition like this, that a growth restricted fetus is the one that fails to achieve its growth potential. And that seems to be gaining ground, and we'll know why. But first of all, the impact of fetal weight. We know that it affects a lot of pregnancies in India. It is associated with adverse perinatal outcome, abnormal long-term neurodevelopmental outcomes, long-term cardiovascular dysfunctions, and metabolic syndromes. So my talk, well, identifying the small fetus will occupy a small little portion of this. Distinguishing the SG and FGR is important, and follow-up. Well, follow-up, the role of Doppler. And that is why this has got several aspects to it. So before we move on, let us see what was taught to us and what we learned over the period of time. That was the traditional types of IUGR. That was the symmetrical growth restriction, where the entire baby was small. It is, of course, less common. There was a global growth restriction. Head was also generally smaller. And these were generally with rubella, toxoplasmosis, maybe genetic abnormalities, and so on and so forth. And then the other one was the asymmetrical growth restrictions. And these were the ones which we were probably identifying later on in the pregnancy, where the head continued to grow. And there was a lack of subcutaneous fat, which was leading to thin and out of proportion body with the head. This indicated that the fetus encountered problems generally later. And that was preeclampsia, hypoxia, hypoglycemia, and so on and so forth. And that is what we've been doing all this time. So identifying the small fetus. For example, this situation comes to you. This is a fetus at 37 weeks. The growth is less than 10 centile. Anatomy scan has been normal. Umbilical artery in CPR, cerebroplacental ratio is normal. Should we deliver? Why not? But then some of them will say, let us wait for some more time, because the growth is actually only slightly less than 10 centile. So should we wait till 39 weeks? Should we wait for 1 more week, 2 weeks? And these are some of the questions which are generally confusing. So let us address all of them. Now, first of all, the biometry. Now, as the fetus grows, we start measuring the fetus. That we know that a BPD, HC, ACFL, we all know that. Here it is important to note that we have deliberately made the size of the abdominal circumference large, because that is to emphasize the importance that the abdominal circumference plays for the fetal weight estimation and not the size of the baby. So it reflects the nutrition of the baby. So fetal size is measured by head, body size, skeletal size, estimating fetal weight, and composite variables. These are the most essential components of measuring the baby. So we can use a whole lot of parameters to assess the fetal growth, and it is important to see the symmetry of the baby. So assessment of the size will require reference ranges, and we are now putting on growth charts in all our reports. So, but let us also remember that dating a pregnancy is the most accurate in the first trimester. Dating scans, please, the error is just about 3 days plus minus. So whenever there's a patient, we must always refer to the first trimester scan and then extrapolate from there, because that is considered to be the most accurate and the most robust measurement. So that is the first trimester measurements which are most important. Please also remember that it is an exponential growth up to 12 weeks. Please remember, and we must measure the outer edge of the cephalic pole to the outer edge of the fetal drum. Avoid excessive curvature. Do not include limbs. Do not include yolk sac. And we must express it as millimeters and weeks and days. And there we are all set to go. Because when we are going to remeasure the fetus, when it's probably at 18 weeks or something, we are going to extrapolate and we are going to put it on the growth charts. And then we will know whether the baby is growing symmetrically, whether the baby is growing well, or it is falling off the charts. So measurement of fetal symmetry is equally important, which means head to abdomen ratios, that is head circumference divided by the abdominal circumference. Head to femur ratio is important. So these are the symmetries or the body proportions that are equally important. And then after the few words on the fetal biometry, I must tell and talk about few things that we must keep in mind when we are doing a Doppler. Because in the third trimester, when the baby comes to us, we must do a Doppler. In fact, we are doing Dopplers even in the first trimester. Now for the measurement of screening for the preeclampsias. Now often a question is asked which indices to use, whether it is S upon D ratio, RI or PI. Well, we are now doing PI values because it shows a linear correlation with vascular resistance, as opposed to both S upon D ratio and RI, which show a parabolic relationship. So additionally, PI will never approach an infinity wherever there's an absent or a reverse diastolic values. So PI is commonly used. Also, there are few factors. Now, 5 more slides to know about generally when we are doing a Doppler, because please remember, once you detect a baby which is small, we are going to switch on the Doppler. So PRF has to be adjusted nicely. We should not be letting the PRF values get the vessels to be overflowing, which means that this was a low PRF, this is a good PRF, and this one is too high, where the vessels are not filling up properly. At these, please remember, just 5 slides for all the vessels that we should interrogate in an FGR. So enough gate width to include the entire diameter of the vessel, whichever that we are measuring, umbilical, uterine, or middle cerebral artery, because if the gate is not sufficient, we will not get a good graph. Also, the wall filters have to be set appropriately. For example, in the image on your left side, you'll see that there's a very high wall filter. Thereby, we have a false impression that this is an absent end diastolic flow, whereas it is not. Also, the sweep speed is important. Please remember, we should not put it too low, too high, and we should put it appropriately where we can get 2-3 waveforms, and that is good enough to see the diastole and the systole. Fetal breathing movements, please remember the fetus has to be absolutely quiet when we are doing a Doppler, because that will disturb the whole situation. Also, the maternal the mother should lie semi-recumbent, because please remember, if the baby is also doing hiccups or the baby is moving, hold on, let the baby be quiet, and then you proceed ahead. So location of the uterine arteries, please remember, this is not the scope of my lecture, but I'm just talking about the crossing of the uterine arteries. We take the probes on either side of the uterus at the uterocervical region. We pick up the internal iliac arteries, and the vessel which is crossing is the one which is the uterine arteries. And we take a Doppler, we interrogate the Doppler, and we get a uterine artery on both right as well as on the left side. And it is the mean PI values which are important. Umbilical artery, yes, we take a free loop. This image will demonstrate color and pulse wave Doppler used to evaluate the umbilical artery. Please remember the sample volume and the insonation angle, which should be less than 30, and so on and so forth. So please remember the settings have to be really good, and the Doppler gauge should be of the same size as that of the vessel being interrogated. So these are few words. And also in the twins, in matters of twins where one fetus is FGR, that is a tricky situation where, please remember, if they are twins, please try to interrogate the umbilical artery at the level of the insertion of the twin. Otherwise, it might get confusing, and we will not know that which cord belongs to which twin. Middle cerebral artery, briefly, an axial section of the brain that we know, which will include the thalami and the sphenoid bone wings. Color flow mapping should tell us what is the circle of Willis, and we take the circle of Willis and interrogate it at a very, very less angle. It should be close to 0 to get a very good Doppler, spectral Doppler graph. And the angle between the ultrasound beam is important. Care should be taken not to avoid we should avoid pressure on the fetal head. So then now we've got the Doppler, now we've got the growth. And now we come on to fetal growth charts. And not only the fetal growth charts, the Doppler charts are equally important, because the Doppler charts are going to tell us what is the centile of the PI value of the umbilical artery for that gestational age. And that should also be displayed, and that should also be reported. So fetal growth charts, this, as you can see, is a normal pattern, and this is a constitutionally small fetus. Why we said that it's a constitutionally small fetus is the reason that pardon? Hello? Can you hear me?
Yes, sir. Please go ahead.
Now we can see that here the growth charts are going are falling slightly, falling below the normal, below the red lines, but the umbilical artery is normal. So we are reassured that this could be a constitutionally small fetus. And then there's another situation where the fetal weight or the fetal growth is falling below 3rd centile, and the umbilical artery is abnormal. And we are fairly sure that this could be one of them, which is an FGR baby. So now we'll further talk about what FGR and what we need to do. Here we see that it is a continuous fetal growth at around 5th centile throat, and if the parents are smaller on a twin gestation, this can be perfectly normal. So not all small babies are FGR. We have to see the many factors, genetic factors, environmental factors, and so on and so forth. Please remember, growth is dynamic. And if on single reading it is a plus minus situation, please go for an interval growth and then take a diagnosis. Because please remember, growth is dynamic. So if the growth, every chart is telling us that the fetal size is falling off the curves, then we know that this could be an alarming situation. So measurements that fell off the curve are the ones that are abnormal. So abnormal head growth can indicate aneuploidies. Please remember, Abdominal circumference is important because that is the single best measure of fetal nutrition and skeletal growth. If the femur length or the humerus length is falling down, that could ring a bell for skeletal malformations. Please also remember that it is the maternal factors, that is the race, stature, environmental factors, that is the altitude, availability of adequate nutrition in our country and in several other countries, physiological factors, that is altered glucose metabolisms, pathological factors, that is hypertension, uterine malformations, and many other complications like preeclampsia also. Now, customized charts have come in, but then there has been we have to be very cautious on using customized charts because it cannot happen that a baby in Delhi will have a different growth parameters than a baby in Mumbai or baby in somewhere else. So therefore, we have to trade very cautiously in this, and lot of customer charts have come and lot of customer charts have gone. But what we must remember is that the fetal growth will happen. When does the fetal growth happen? It starts happening at around second trimester, and that is the time when the growth will accelerate. For this, we need to take a look at the growth of the placenta. Please remember that the placenta is really growing even in the first trimester, and this growth of the placenta is exponential. If we analyze this curve, we see that the placenta develops first, and it is mainly in the third trimester that the fetus will grow rapidly and the adipose tissue gets deposited in the fetus. Also, then a small proportion of the small but appropriately grown babies, and small due to growth restriction, and these are the various factors which can lead to a small baby. Small but appropriately grown could be extrinsic, could be drugs, could be toxins, could be infections. Fetal factors could be aneuploidies, gene disorders, structural abnormalities, other syndromes. There could be maternal factors like hypertension, preeclampsia, Apla syndrome, thrombophobia, and the placental factors, that is abnormal placentations, uterine anomalies, chronic abruptions, so and so forth. But what we have to now do is that suppose we face a situation where the fetus is small, then we must exclude the primary fetal defects. And if we must exclude the extrinsic causes, and if it is a fetal growth restricted baby, we are dealing with a situation of placental insufficiency with a poor perinatal outcome, and possibly if it is early enough and a severe one, we may face a situation of intrauterine fetal death, and Doppler will show us signs of adaptations. However, if it is a SGA baby, it is constitutionally good normal baby, the perinatal outcome will be normal. There are no signs of adaptation. And these are the signs of adaptation which we must look at once we encounter a small baby. For example, do we mean that an abnormal umbilical Doppler will have an FGR? Not anymore. And why we are saying that just on umbilical artery we cannot diagnose an FGR is because of these studies by Savchav. This came in 2013, reinforced in 2019, where there was a huge meta-analysis done. Now this graph, if you see very carefully, these are the umbilical arteries which are abnormal. These are the normal umbilical arteries. And since the fetus will start to become generally smaller, later, say in the third trimester, the umbilical artery is generally normal at this stage. So if we see the umbilical artery, the normal and the abnormal hemodynamics, we remember that if the placenta is working less than 30%, the cardiac pump functions will start getting affected. And then if we finish it at umbilical artery, we are creating a little mistake. And why we are doing that is because we'll come back to this study. If we combine it with the middle cerebral artery, normal and abnormal hemodynamics, normal oxygenations, mild vasodilation, as you see, normal, this one is normal. The graph at the top is normal. The graph in the middle shows a mild vasodilatation, and the graph at the below is marked vasodilatation. So what does this tell us? This tells me that if I must take an umbilical artery PI and we take a MCA PI, I divide the PI of the middle cerebral artery by the PI of umbilical artery, and I get a cerebroplacental ratio. And all the studies so far have told us that the cerebroplacental ratio is more sensitive than umbilical artery or MCA alone. And it is the cerebroplacental ratio, if it is less than 1, that should ring us a bell. So prognostic criteria for pure outcomes and also diagnosis of FGR is largely now these days on CPR, and that, as I told you earlier, is dividing of MCA PI by umbilical PI, and if it is less than 1 or 1.05 to be more precise, also the uterine artery PI, if it is more than 95th centile, and the fetal weight, if it is less than 3rd centile, any one of these three, we must remember that a small baby facing these three situations, we must label it as FGR and treat such a baby like so. We must remember that what we are looking here is a preclinical phase, which means that if it goes into the clinical phase, the fetus is going to be hypoxemic, which obviously, if the cerebroplacental ratio becomes abnormal, then we know that it is in the clinical phase. And but it has not gone into deterioration, because if it is deterioration, then the ductus venosus will get abnormal. This is another study by Figueras, and Figueras we know has done a lot of work on FGR, and this one came in 2015, and where they studied 509 pregnancies with SGA, and umbilical arteries were normal. But if any of these three parameters were considered, then we see a probability of a poorer outcome at 40%, and 40% is a large amount. And that is in all the small babies. So remember, umbilical artery alone was normal in all of these. So which tells us that apart from the umbilical artery, we have to take in factor other parameters, that is any growth which is less than 3rd centile. Uterine arteries also will play a factor, and these are the ones which are predicting an adverse outcome in all such pregnancies. So what was the graph earlier? This was the graph which I showed you earlier. When we considered only umbilical artery, the risk was only 16%. But if we combine all the other factors, it changes dramatically. And look at this one. So if we add all these factors, the risk rises to nearly 65.5%, which is 2/3 of the population. So in all small babies, we have to consider all these factors. That is the cerebroplacental ratio, we have to consider the uterine artery, and we have to see if it is less than 3rd centile, the fetal weight. Now we come to Delphi consensus. Delphi also said that the fetal size, which is less than 10th centile from a population-based reference, and majority of constitutionally small babies are healthy fetuses. That was SG. And small fetus, and this Delphi consensus has also come last year. And also they've been talking about FGR. The fetus not meeting its growth potential. And this is Delphi consensus. And appropriately gestational age fetus, which is more than 10 centile, may remain undiagnosed if we don't do a Doppler. And that is a word of caution, whereby in the 3rd trimester, we might just consider doing a Doppler whenever the fetus comes to us for a growth estimation. So, there have been several people who've been talking that why don't we call it failure to reach growth potential, FRGP babies, rather than FGR, because FGR has already been talked so much. IUGR, FGR were earlier associated with SGA, and people still get confused with FGR and SGA. So failure to reach growth potential could be a good term for the future. So fetal smallness, we've already discussed before. We have to exclude primary defects. We have to exclude the other factors. This is another study, Barcelona group. The total number of small babies studied, 1190. And we have seen that the fetal morbidity depends a lot on the gestational age at which it sets in. So at approximately 27 weeks, and this is 27 weeks, we see that the morbidity of SGA fetus, which is a blue line, is almost double than that of appropriately grown babies. But as the gestation progresses, the morbidity reduces and almost matches each other at around 31 weeks. So an FGR baby has to have intrauterine existence of about 32 weeks for it to have a good chance of survival and a good chance to have a good neurodevelopmental outcomes. So distribution of cases when FGR normal, please remember late, mild, no IUFT, 37 weeks, problem detection. A question, is it FGR or SGA? And if it is early, that is severe high risk IUFT, preterm problem timing delivery. And these are the questions that were told to us by this study in year 2013. Whereas if it is early, the problems are severe, there's a high risk problem timing delivery. And if it is a late, the problems could be milder. There is no question of an IUFT. Normally at 37 weeks, you can take the baby out. So ductus venosus, very quickly, again 2 slides, the ductus venosus, why we've taken the ductus venosus at this stage. We've already discussed about cerebroplacental ratio, the uterine arteries, but now we must see what are the changes in any vessel according to acidemia in the baby. And please remember, ductus venosus will play a crucial role in telling us when to deliver the baby. And we all know where to take the ductus venosus. But please remember, if it is abnormal, we must remember to repeat the reading, because ductus venosus can be modulated by ductus venosus diameter. There could be a portal venous resistance. The hemocrit could be increased, leading to increased ductus venosus shunt. There could be humoral factors like prostaglandins, which may interfere in the readings of the ductus venosus. So please remember, any abnormal ductus venosus, please repeat the readings and take at least 3 and over some time. And we know that this is a normal ductus venosus and this is an abnormal one. We do not wait for the reversal of the A waves anymore. We just take the PI values, and any PI value above the 95th centile should ring a bell that there is something wrong. Umbilical vein, again, a critical value for umbilical vein, but we don't see umbilical vein these days because ductus venosus is good enough to tell us that the baby is going to severe acidemias, asphyxias, and risk of perinatal deaths. A word about aortic isthmus and why it's important in FGR babies is that consider a situation where the baby is FGR and it is just about 28 weeks, but we want to prolong the intrauterine stay for another 2 weeks, but we don't want a neurodevelopmental insult, or we don't want a brain insult due to deoxygenated blood going into the brain. So the aortic arch, please remember, the aortic arch will have 3 branches, and it is the portion after these 3 branches that is the aortic isthmus. And if we take a spectral Doppler at this point, we know that the aortic isthmus, this one is normal, there is a diastolic flow, good one. This is a spectral Doppler where the diastolic flow is very less, and this one is the one which is reversed. The reverse diastolic flow means that the fetus is now sucking the blood which is going to the descending aorta up into the brain, which means that there's a severe brain sparing effect. Not only that, it's putting up the blood which is impure into the brain. And that is one point where we have to be very careful. Gratekos and Barcelona group were very vocal about aortic isthmus, but then some people now say that aortic isthmus may not be very useful. The debate continues, and that is the good point about doctors, that we have to keep our mind open for all of that. But however, I feel personally that yes, aortic isthmus can play a big role in telling us when to deliver the baby once the baby is at a critical point. So then one word about the cardiac functions. This is one cardiac function which can happen in FGRs, and FGR babies, we know that cardiac remodeling can happen in FGR, neurodevelopmental remodeling can happen in FGR, and these are some studies which can tell us that what are the remodeling that is happening in the fetal heart, because these such babies, if they are suffering from severe FGR, they can land up in severe cardiac dysfunctions later on in life also. So now we come back to the role of Doppler in FGR and critical. Now we know that this is an FGR baby. The fetal hypoxia acidosis has set in, and then what we do, we know that there's a placental disease, we know that there's a compensation going on, and we don't want a decompensated hypoxemia, which means that the aortic isthmus should be normal, the CPR should be normal, and we don't want a situation beyond that, which means that if it is a mild hypoxemia, we can continue as long as there's no cardiovascular adaptations, which means that if compensated hypoxia, we can continue, we can afford to do that. But it is the later stages which are more important. And that is why Barcelona group came us with 4 staging, that is a low expected fetal birth weight, which is less than 3rd centile. That means that it's an FGR with mild placental resistance. That is grade 1, stage 1. So with the ones which are severe placental resistance, stage 2, the one with severe hemodynamic adaptation, stage 3, that is low suspicion acidosis, and stage 4 is a high suspicion of acidosis and high risk of fetal death. So we'll take one by one. For example, this is an FGR and the management protocol, according to severity, I do a Doppler and we find that there's an absent and diastolic flow, that is stage 2, then we know, and the delivery should be done in 34 weeks according to Barcelona group, and we must follow up these babies every 2 to 3 days. However, if it is a reversed end diastolic flow with the changes in ductus venosus, that is stage 2 progressing to stage 3, and we must follow accordingly, and we must be more careful on these babies, which means that if it is stage 3, then we must think of delivering at around 30-31 weeks with a daily follow-up. And if we must prevent it from going into stage 4, and that stage 4 is just 4 to 7 days apart from that, remember. So the stage 4 is when the ductus venosus becomes absolutely abnormal, there are high PI values, the A waves are reversed, and that is when the biophysical score is also now showing changes. And then please remember that we have to take the baby out, otherwise we might face an intrauterine fetal death within 1 or 2 days. And that is a situation where a CTG will starts showing some changes, and that we should not be reaching that stage these days anyways. So that is the late deceleration, and I don't know if there's anybody brave enough to reach that stage. So integrated management of FGR, identify fetal smallness. If it is less than 10 centile, we must do a CPR uterine artery. If it is to distinguish between SGA and FGR, we must do an expected fetal weight. If it is less than third centile, if the CPR and uterine artery is normal, then we know for sure that it could be a SGA. If it is less than 10 centile only, but if it is less than third centile, then we know that we have to identify the stage at which this baby is. If it is stage 1, we can deliver at 37 weeks, stage 2, 34 weeks, stage 3, 30 weeks, and stage 4, anytime. And that is where the role of Doppler is so crucial. So we need to know why we are conducting a Doppler. We need to know which vessel and where to interrogate. The techniques have to be followed properly. I'm sorry, because of lack of time, we cannot talk about techniques all in one go. We must also be aware of the pitfalls, repeat the readings whenever we find an abnormal reading, incorporate the percentiles for the gestational age for each and every Doppler reading. RT-Kismet studies may be helpful. So to sum up, the main goal in FGR is identifying the FGR babies, small fetus, that is expected fetal weight, 10 centile must be divided into FGR, that is placenta, poor perinatal and long-term outcome, or SGA. We don't know whether the placenta is working or not, and perinatal outcome is normal, and there is no poor long-term complications. So early and late onset FGRs represent two distinct phenotypes of the same disease. Clinically, a single stage-based protocol allows optimizing decisions in all such cases. With this, I thank you for a very patient hearing.
Thank you so much, Dr. Vivek, for the insightful and very well descriptive talk. Moving on to the next session, I would like to invite Dr. TLN Praveen to present their talk on 11 to 14 weeks fetal evaluation, the great big window of opportunity. Dr. Praveen, I would request you to please unmute your lines.
Yes, I think I'm unmuted. I will share my screen now.
Sure, sir.
Thank you. Thank you again, and I would like to thank the organizers of Pune Gynaecological and Obstetric Society, as well as joining with SFM. It's going to be a huge area where we are going to work together so that we can achieve many goals which are planned to be. So to start with today's lecture, I've been asked to share my experience on this great big window of opportunity that is between 11 to 13.6 weeks. The moment we talk about 11 to 13.6 weeks, we basically think in terms of first trimester screening, that is the aneuploid. But then there are many more that we can evaluate in this particular window. As Dr. Vivek has taken us through Doppler, and he was really worried about the differentiating between small for gestational, FGR, Doppler, and all those aspects. Now we have a huge list here. where we are going to talk about the accurate dating, because the first trimester there is 11 to 14, we call it as a dating scan. Then we have to differentiate or detect multiple pregnancies, identify its chorionicity, screening of aneuploidies, and early diagnosis of major anomalies, and predicting preeclampsia. So this is the agenda for today's talk. And in this one, first let us start off with the accurate dating. As we all know, the 11 to 14-week scan is known as the dating scan, in which we basically depend upon the crown rump length. As we all know, crown rump length is the most important biometric parameter. It is useful in assessing the gestation age, particularly in the first trimester, and its accuracy is as high as plus or minus 5 days. That is the 95th confidence range. As this is because at this stage, there will be very little biological variation. That is the reason why it is so very sensitive in giving us the gestational age. Now, as we measure the crown rump length, that is the largest diameter of the embryo, excluding the yolk sac as well as the extremities. Now, when you take the crown rump length, basically we need to understand that this is the baseline measurements for subsequent age assessment, not only the age assessment, but also the growth assessment, because this forms the baseline on which we depend upon and then progress and try to evaluate the growth pattern that is there, which once you put them on the growth charts, you can positively diagnose the possibility of small for gestation, appropriate for gestation, for fetal growth restrictions. Now, another important fallout of this is that when you have a decreased crown rump length at this gestational age, please remember there is always a possibility of a chromosomal abnormality in the form of a trisomy 18 or a triploidy, which are usually associated with growth restriction. That is one good feature that we can pick up by taking just a crown rump length. Now, how do we take the crown rump length? There are certain landmarks that we have to follow in getting the crown rump length, because accurate measurement is extremely important. As we all know, that is an extremely sensitive parameter in dating the pregnancy. So first and foremost thing, what we need is a mid-sag, supine mid-sag view, in which the fetus is in neutral position. How do you know that it is in neutral position? We know that there is no hyperextension of the embryo or hyperflexion by identifying a small pocket of amniotic fluid just below the chin and just above the chest. So this is the ideal situation where you can take the measurement. Then you need to define the crown as well as the rump. And once you have done, then you can take the gestational age, the crown rump length, excluding the yolk sac as well as the extremities. Remember, always magnify the image in order to appropriately. In any of the OBGYN practice, the most important trick or the tip that I would like to pass on is that try to get as magnified an image as possible and try to take as many cine loops as possible. So these are the two small important tricks that you have to usually practice whenever you are trying to evaluate a fetus or a gynecological problem. Now, coming to the identification of multiple pregnancies. As we all know, the incidence is getting more and more, basically because of the assisted reproductive techniques that are being practiced. Not only that, the aging maternal population and late conceptions are another factors which are also responsible for multiple gestations. Now, why are we worried about multiple gestations? Because it has a higher risk of pregnancy for both the fetus as well as the mother, and there is a perinatal morbidity which is almost twice as high as a singleton, and mortality is almost 6 to 8 times of that of the singleton. So the complications like preterm birth, fetal growth restriction, anomalies occur with higher frequencies. There are certain unique abnormalities that are unique for a monochorionic diamniotic twins, such as the twin-to-twin transfusion, tops, traps, as well as the taps are also known. So these are all the various things which prompt us to be much more alert in identifying the multiple gestations. And when we have a protocol that we need to follow is that first and foremost thing, confirm the pregnancy and then the multiplicity, confirm the viability. Dating the pregnancy is same as that of a singleton, and identifying the chorionicity and amnionicity is an extremely important factor, because as we have already understood, the chorionicity is the most important thing, because if you have a multi-chorionic fetus, obviously it behaves almost like singleton. Whereas if you have a monochorionic fetus, there are certain unique abnormalities that we need to keep in mind. That is the reason why you need to identify the chorionicity. Then comes the screening of aneuploidies, which is the same, which has different protocols to be followed as far as the multiple gestation is concerned, and then identifying the anomalies, particularly the discordant anomalies, and which will help us in doing a selective reductions and assessment of the growth pattern. That is because there will be a selective fetal growth restriction that can be possible in these situations. Now, detecting unique abnormalities which are pertinent to MCDA and Momo twins. Now, what is this chorionicity? The chorionicity is basically the number of placentas. Basically, when we take the fertilization, if there are two ovumes which are fertilized by two separate sperms, then we get what is called as the polyzygotic embryos, wherein you have unidentical twins. Whereas if you have a single ovum and it is fertilized by a single sperm, then the merula or the blastocyst can also cleavage, and it can result in what is called as the identical twins. So the number of placentas basically depend in polyzygotic twins basically on the number of zygotes, whereas in a monozygotic twin, the chorionicity is basically because of the time of division. So how does that happen? If the division takes place in less than 4 days, then it results in a DCDA twin. If it occurs back between 4 to 8 days, there is a possibility of a MCDA. If it is between 8 and 13 days, there is a Momo twin. And if it is after 13 days, there is the possibility of a conjoined twin. So this is how the twinning or the cleavage or the division will help us in identifying the chorionicity of the fetus. Now, let us get to the chorionicity, amnionicity as far as the dizygotic twins are concerned. 100% of them are dichorionic. This dichorionicity, whereas in a monozygotic twin, 75% of them are dichorionic, whereas 25% of them are monochorionic. Of this, if you can have a dichorionic, you may demonstrate two separate placentas, or you may demonstrate a single placenta, which is basically a fused placenta. So the important aspect of it is that we need to differentiate between a fused placenta and a shared placenta. The shared placenta is the one, this is the one which is a shared placenta, where there is a single placental tissue and a thin intertwin membrane, where this placenta supplies the nutrition as well as the oxygenation for both the fetuses. Whereas in a Momo twin, there is not even a intertwin membrane, and there will be a single placenta, and this accounts to only 1% of the multiple gestations. Now, after understanding the chorionicity, we need to understand which is the earliest time then we can identify the chorionicity. Remember, the chorionicity is best identified in early gestation, that is less than 10 weeks. The simple rule is the number of gestational sacs are equivalent to number of chorions. So this is the simplest way of identifying the chorionicity. There is another thing that has been suggested is that there is a possibility that the number of yolk sacs, that is are equivalent to number of amnions, but then this I hold it because it is not just the yolk sacs that are going to be there. You have to identify the intertwin membrane, but at gestational age of 10 weeks, less than 10 weeks, it is really difficult to differentiate or identify the thin intertwin membrane. That is the reason why you may have to try and evaluate the yolk sacs, number of yolk sacs will indirectly indicate that there is a amnionicity. Now, after 10 weeks of gestation, it is the number of placentas or the presence of twin peak sign or the lambda sign, which tells us that there is a fused placenta. And if it is a T sign, that is the intertwin membrane abruptly ending into the placental tissue, it is probably a single placenta, that is because of the shared placenta. And not only that, even the intertwin membrane thickness can also help us in up to 20 weeks of gestation. Of course, the fetal gender, which is not possible for us to make use of in identifying the chorionicity. So these papers are very, very obvious that they suggest that the chorionicity is best identified in the first trimester, particularly less than 10 weeks. This is a classical example where you have a multi-chorionic, multi-amniotic pregnancy. Now, as I said, the number of yolk sacs are suggestive of an amnionicity. As you can see here, you can have a single gestational sac, but you have an intertwin membrane and a single placental tissue. Whereas, if you see this one, there is only one yolk sac and there are two fetuses in a single gestational age. So basically, you need to identify the amnion, which is important, which is possible. 1 second. Which is possible after 8 weeks to assess assign the amnionicity. Before that, it becomes very difficult. That is the reason why you try to identify the yolk sacs and try to identify the amnionicity. Now, if we have a situation where we can separately demonstrate two placental tissues, then we are sure that we are dealing with a diamniotic dichorionic placentas. Whereas whenever we have a single placenta, which could be a fused placenta or a shared placenta, in that situation, we need to take the help of what is called as the lambda sign, where you can see the trophoblastic tissue, which is invading in between to the intertwin membrane. So classically, the intertwin membrane thickness also can help us to some extent, but this is very subjective, because in an MCDA twin, there are only two membranes, that is two layers, that is the amnion and the chorion, whereas in a DCDA twin, we have thick membrane, that is 4 millimeters, that is two amnions and two chorions. And in a monochorionic twin, there is absence of dividing membrane, so it is monoamniotic, hence it is called a monochorionic, and always it is monochorionic. Now, when the division takes place after 13 days, there is always a possibility of a conjoined twin. As you can see, it could be a thoracophagous, omphalophagus, or thoracoabdominophagous. All those situations can be there. Now, coming to the first trimester screening of aneuploidies, we know that there are certain screening markers that are available which will help us to identify or to screen these fetuses for aneuploidies. These screening markers, that is the ultrasound markers, are gestational age dependent, which is based on the crown rump length, which is a biometric parameter to date the pregnancy in the first trimester. So all of these screening markers are gestational age dependent, and gestational age is identified by the crown rump length. Now, remember, most important thing is when you take the maternal age, gestational age, and the markers, the sensitivity of identifying or screening aneuploidy is only about 80%. Whereas if you can combine that with the biochemistry in the form of free beta HCG and PAPE, in that situation, these are the placental products, and along with the ultrasound markers, the detection rate goes up to almost 90 to 92%, and this will help us in reducing the number of invasive procedures from 20% to 3%, and also increases the detection rate to 95%. So this is one of the things that we have to understand. Now, general principle is that every fetus has a risk of chromosomal abnormality, and the gestational age as well as the maternal age are the ones which decides the a priori risk of the fetus. But then a priori risk, it depends on the maternal age and gestational age. But then what we are interested is not in that a priori risk, but what we are interested is in fetal specific risk or patient specific risk. And this can be calculated by multiplying the a priori risk with the likelihood ratio. This likelihood ratio is the one which is obtained by taking the ultrasound markers into consideration. The likelihood ratio is nothing but which is calculated by dividing the percentage of chromosomally abnormal fetuses with percentage of normal fetuses with the same marker. So when once you have that one, that likelihood ratio multiplies the a priori risk, which gives us patient-specific or fetus-specific risk. Now, there are certain OSCAR one-stop clinics for assessment of risk, where they take into consideration the maternal age, gestational age, history of previous defects that could have been there, or nuchal translucency measurements, and then the biochemistry. And after taking all these things into consideration, they counsel the patient, and wherever it is required, they suggest invasive procedures such as the CVS or the chorion villus sampling, particularly in the first trimester. Now, how do we approach this? We approach this by taking the maternal age, as I said, gestational age of the fetus by taking the crown rump length, and then the nuchal translucency, fetal heart rate, and serum biochemistry, as well as the additional ultrasound markers. Now, I'll just take you through some of these markers because it is one of the part of the 11 to 13 week scan. And in this, the nuchal translucency is nothing but the collection of fluid under the skin, behind the neck. And then it can be unilocular, septate, or it can be there limited to the neck, or it can extend all throughout the fetus. The incidence of chromosomal abnormalities increase to the size of the, with this increase in the size of the nuchal translucency. Remember that this NT disappears in the second trimester because this nuchal translucency resolves, and it evolves into what is called as the nuchal edema or the cystic hygroma, or at the same time it can also be in the form of a nuchal pad thickness. Now, we all know how to take a nuchal translucency. I'm just showing you these images because First and foremost thing, you need to magnify the image. At the same time, you need to have neither a hyperextended or hyperflexed fetus, wherein you can identify the nuchal translucency. Keep the horizontal marker on the on, and that's how you measure the nuchal translucency. Now, when you have this sort of a situation where there is an increased nuchal translucency, with the quantum blend larger the nuchal translucency, the risk of chromosomal abnormalities are higher. 75 to 80% of chromosomal trisomy 21 fetuses will have a nuchal translucency which corresponds to 95th centile, and then the maternal age can be combined with the fetal NT as well and provides the first trimester screening for chromosomal error. Now, these are empirical figures, but we don't really take them into consideration. Quite often, what we are interested is in identifying the moms, but then for a general application, for an easy application, you can consider that whenever the nuchal translucency is less than 2 millimeters, you can consider it as a euploid. If it is more than 3.5, which 3.4, which corresponds to almost 95% percentile, then you need to think in terms of trisomy 21. In trisomy 18s, you have nuchal translucency much bigger, much more. That is 5.5, and trisomy 13, it is 4 point, and Turner's with cystic hygroma, it may go up to even 9.2 millimeters. Now, why do we have to take the heart rate into consideration? The heart rate is an extremely important thing. As we all know, at about 10 weeks of 14 weeks of gestation, fetus will have a heart rate between 140 to 150. In trisomy 21, there is a mild increase in fetal heart rate, whereas in trisomy 18, there will be a mild decrease in fetal heart rate. But in trisomy 13, there will be a substantial increase in heart rate. That is, the tachycardia will be seen in trisomy 13. So quite often, if you take just the nuchal translucency, or you take the structural abnormalities which are common with trisomy 18 and trisomy 13, then the situation becomes very difficult to differentiate one from the other. In those situations, you can still use the possibility of a fetal heart rate. Now, coming to biochemistry, we know that we normally double markers are the one which you use. We take the nuchal translucency, fetal heart rate, as well as the serum pre-beta HCG and PAPA to identify almost 90% of trisomy 21 with a false positive rate of only 3%. When do we do this biochemistry? Quite often it is advisable to do it at 11 weeks. And then, but the nuchal translucency is comfortably done at 12 weeks. Not only that, the structural abnormalities are also identified at 12 weeks. That is the reason why we try to compromise and try to get it, because we can't have the patient thrice to our clinics. So it is essential that we can do all the three at one sitting, that is at about 12 weeks, where you can do the biochemistry, you can do the nuchal translucency, as well as the structural evaluation. So when we have a serum biochemistry, the way we are going to interpret is that when in an euploid, the free beta HCG as well PAPA is about 1 mom. Whenever there is doubling of free beta HCG and half of PAPA, you need to think in terms of a trisomy 21. Whereas in trisomy 18 and 13, there will be decrease in free beta HCG as well as PAPA. So these are the things that we have to keep in mind. So now once we have done that one and we have assessed the risk, and we categorize them as high risk where it is 1 in 50, obviously that then the possibility of an aneuploid is very high. In this situation, we would like to offer them a Korean villus sampling or an invasive testing. Whereas if the fetus falls into a risk category of 1 in 1,000, so we know that it is a very low risk category. In that situation, we'll ask the patient to come back for an anomaly scan. But there are certain 16% of the cases where they fall into this intermediate group, where the risk can be between 1 in 51 to 1 in 999. In that situation, we can offer them an NIPT for the screening, which is very powerful tool because its sensitivity for trisomy 21 is as high as 99.9%, false positivity is less than 0.5%. And then, if not, at least we can offer them an additional markers such as the nasal bone, ductus venosus, and tricuspid regurgitation. That is the flow across the tricuspid valve. Because these are again, if you can put them all together, that is taking nuchal translucency, nasal bone, tricuspid regurgitation, as well as the ductus venosus abnormality, the detection rates are as high as 94%. So that is one of the things that we have to understand. And then in our busy practice, if you have time, it is always better to do all the four. If in case if you don't have time and wherever there is a high risk or intermediate risk, better to offer them the additional markers such as these. These are the additional markers like the nasal bone, ductus venosus, as well as the tricuspid regurgitation. So with this, we move on to the assessment of structural abnormalities in a euploid fetus. Now we have decided that the fetus is a euploid, and then there is no chromosomal involvement. Then in that situation, we need to assess the structural abnormalities. We need to understand that 1.09% of euploid fetuses can have structural abnormalities, out of which 31% are always detectable, 43% are sometimes detectable, and 23% are not detected. So the one word of caution is that limitations in detecting anomalies. Please remember that at this stage of pregnancy, it is sometimes very difficult, very tricky, and we are in the learning curve where we have to master this technique of identifying structural abnormalities. And always please ask them to reconfirm it at about 16 to 18 weeks before a definitive decision is taken. Now, these are the various anomalies which can be 1 to 49% detection rate is spina bifida hydrocephalus, and then we have 50 to 99% detection rates. 100% detection rates are the acrania, anencephaly, ectopia cordis, and encephaloceles, whereas 0% are the ones which are the evolving abnormalities which will evolve over a period of time, particularly along with the gestation age. So these are the things that we have to keep in mind while assessing the gestation age. As I said, it is always essential that we need to understand the size does matter in evaluating the structural abnormalities. That is the reason ideally it should be about 12 weeks of gestation, which almost corresponds to about 63 to 84 mm. That's 84 will be about 13 weeks, but 64 millimeters will be about 12 weeks of gestation, which will be ideal time to identify the structural, evaluate the structural abnormality. When you are trying to evaluate the structural abnormality, you need to follow a systematic method. First and foremost thing is, when you try to evaluate the structural abnormalities, we need to start from the fetal head. You can take the transverse section or the axial section of the fetal head, gradually move down. As you can move down, you can see the choroid plexus on either side of the midline. This is what is called as the butterfly sign, where you can have the interhemispherical fissure as well as the choroid plexus on either sides of the midline. And then you move down a little more, and then gradually you come to the fetal face, where you can see both the orbits and you can also see the lens. And then you have the premaxillary triangle, where the palate is formed by the base of the premaxillary triangle. And then you go a little more down, then you can see two ossific centers here of the mandible. Whenever you find these two separate ossific centers, you know that the mandible is normal. Or else if you find a single ossific center, you need to think in terms of a microglossia or a retrognathia. And then we come down to the fetal thorax, wherein you can see the fetal heart, and you can see the four-chamber view, and gradually move down as you can see the fetal heart cardiac activity, and then move down and you can see the fetal stomach, and as you can see here, and then you gradually come down and you can identify the insertion of the cord as well as the extremities appearing, and then you can also see the fetal bladder as you can see here, and the lower extremities which are appearing on either side. So this is how you are going to trace as far as the axial view is concerned. The sagittal view is much more useful for us because, as you can see here in the sagittal view, this is the same as that one you take for the fetal first trimester screening, where you can see the nasal bone, the palate, the mandible, as well as the stomach and other structures, as we can reconfirm by seeing this one. And you can also see the spine very clearly. So these are the things which will help us to identify various structural abnormalities which we come across. Now, this mid-sagittal view is one of the most important views that we need to keep in mind. Particularly, it gives us a lot of information regarding the intracranial abnormalities in the fetus, particularly in the form of the thalamus, midbrain, brainstem, as well as the intracranial translucency or the fourth ventricle and the cisterna magna. Most of the indirect evidences of open spinal defect is identified by identifying abnormalities in the posterior cranial fossa. So these are all the various structural abnormalities which one can come across. And right from the acrania, holoprosencephaly, you see the cephalocele, hydrocephalus, cleft lip, micrognathia, so neural canal abnormalities, obliteration of nuchal translucency, and then you have the Acorn sign, where the biparietal diameter is less, and you can see the pleural fluid pleural fluid on bilateral pleural effusions, and then you can see the congenital diaphragmatic hernia. Cardiac abnormalities can also assess, and the most important sign is the axis of the heart, which has to be taken into consideration. And applying color is an extremely integral part of the evaluation of first trimester cardiac abnormalities, where you can see in this one, there is only a single flow with that, and there is a hypoplastic right heart syndrome, and there is a discrepancy between the sizes of the ventricles, where is a small left ventricle indicating that it could be a coarctation of the aortic abnormalities. Then you have the right-sided aortic arch, omphalocele, bilateral hydronephrosis with lower urinary tract obstruction, and also we can see the limb abnormalities in the form of ectrodactyly. So these are all the abnormalities that can be picked up in 11 to 14 weeks. And this is, as I said, this is a very important section where you can see the nasal bone, you can see the palate, you can see the falx cerebri, and also you can see the thalamus, brainstem, as well as the intracranial translucency, mandible, stomach, and then the insertion of the card, as well as the bladder and the spine. So all these structures can be visualized with a single sagittal section. So there is a great window by using this particular section, which is quite often used for a nasal bone as well as the nuchal translucency, and at the same time to assess the gestational age of 11 to 14 weeks, an ideal situation to even look for the fetal abnormalities. A word about the uterine artery Doppler, because there is a complete lecture on preeclampsia, so that I am not going to go into details. Here, basically, transabdominal route is the ideal situation where you try to identify the uterine artery in the paracervical region. Sample gauge should be not more than 2 centimeters, and the angle of insertion should be 30 degrees, and the peak systolic velocity which you can reach, it should be more than 60 centimeters per second, and the PI is taken into consideration. Remember this, these are again an empirical figures. They are not, quite often we use bombs, whereas whenever you do a mean uterine artery, that is take the right and left uterine artery PIs as well, and then take the mean of the both. Then if the mean on transabdominal, it is 1.83, that is the range is between 1.78 to 1.89, whereas transvaginally it will be a little more, that is 1.98, that is 95/5 confidence level is between 1.93 to 2.0. Mom should be calculated, and this is what the placentia is the one who has projected this, these figures, which can be used in our day-to-day practice in identifying fetuses who are at risk for preeclampsia. So with this, I would give you a few key messages, such as we know that the 11 to 13 week scan is having a great outreach and it has a great potential, and pregnancy dating is done, identification of multiple pregnancies, gestational age, that is the dating is done by gestational age, and ultrasound markers are available in order to assess the possibility of a fetal chromosomal abnormality. That is, it is a wonderful tool in first trimester screening modality, and it's also useful in assessing various structural abnormalities and also predicting preeclampsia. Thank you very much for your patient listening.
Thank you, Dr. Praveen, for the very informative talk. May I please request everyone to please mute their lines?
Yeah, sir. Diksha.
Yes, Dr. Ashwini? Sure.
Yeah, I just wanted to take this opportunity to specially thank Dr. Praveen sir for accepting our invitation and having this workshop in association with SFM. Thank you so much, sir. Our pleasure. Sir, you are muted.
Sir, you are
on mute. To add on behalf of SFM, I would like to really thank Pune OBGY Association for giving us this opportunity and joining with us. And I think wonderful, this workshop will be a real landmark workshop with a great opportunity for both of us to work together. Thank you very much once again.
Thank you, sir.
Thank you, Dr. Praveen. Thank you, Dr. Ashwini. Moving on to the next session, I would now like to invite Dr. Bimal Sahani to present their talk on how abnormalities evolve.
Hello. Before we proceed to that, I would just like to thank Dr. Kilan Praveen for accepting the invitation and actually conducting this fetal medicine workshop. No, Dr. Praveen, thank you very much.
Thank you very much, Harsha. And this credit goes to you and your team for organizing such a wonderful event. And if you see the plethora of topics that you are covering, it's just wonderful and amazing. Thank you very much for associating with us.
Thank you, sir.
Right, Dr. Diksha,
over to you, sir.
Yeah.
Over to Dr. Bimal.
Yeah, I'm sharing my screen.
Sure, sir. Yes, sir.
Can you see my screen and am I audible?
Yes, sir. Perfectly audible, and we can see your screen.
Yeah, thank you, Diksha. And at the very onset, would like to thank Dr. Dr. Harshad and Dr. Ashwini and the complete the Society of Pune OBGY for of course for collaborating with SFM to do this, and thank you very much for making me a part of this. Now I'm going to take you through in the next 30 minutes on evolving anomalies and what are their implications in daily practice. As far as anomaly detection is concerned, we have the NT scan at 11 to 13 weeks, 6 days, which Dr. Praveen has just taken us through. And he's also taken us through that, yes, how we can use this window for detecting anomalies also. And then we have the anomaly scan, which is between 18 to 20 weeks in India. As in the rest of the world, it is done a little later. And this has become a routine. It is part of a protocol for every fetus these days in its journey of the 40 weeks. But the thing is, clinicians and patients want a conclusive answer that the fetus is normal or abnormal by the time of anomaly scan, which in India is 18 to 20 weeks period. Now, second trimester is a good time to screen for anomalies. There's no doubt about it. Best time to look for it. But pregnancy is a dynamic event. So whatever is your expertise, you've done a thorough structural survey. There are still some times when your patient comes to you for a growth scan, there are many surprises that come in the form of evolving anomalies. And there are certain anomalies which are progressive, some are late onset, and some are just not apparent in the second trimester. And that is what we are going to see. And remember one thing, we cannot hasten embryology. The embryology is going to take its own time. And whatever is your law, whatever is the time period that you want to look for it, if there is something which is embryologically going to become apparent only at a particular stage, it's going to happen there. Now, anomaly detection overall, and especially in the later part of pregnancy, also depends upon what is the gestational age at which we are doing it. It also depends upon the type and size of the defect. A large defect may become very, very apparent right at the 11 to 14 weeks, but small defects may not become apparent at that stage. Then there are technical considerations that you have to take into account. What is the type of equipment that is being used? Do we have a good sonographic penetration? So if there is an obese patient, we're going to have impaired visualization in them. Then a very important factor is the experience of the operator as well as the alertness of the operator. Now that is, the alertness is, maybe yes, at 20 weeks, everybody is pretty alert looking for the anomalies. But when the patients come to you for growth scans and all, yes, you are concentrating on the size, on the Leica, on the Doppler, where required. But, you may probably not be very alert as far as looking at the structure is concerned, because the patient has had a normal first trimester and a second trimester scan. Another important thing is whether the patient is a low risk or a high risk. Usually what happens is, if the patient is, the quality of ultrasound is better because we are more alert. So the history becomes very essential. Now the problem is, neither do the imaging people ask the history, nor the clinicians provide the history. So it is very essential that anyone who is doing an ultrasound ask the history, maybe not necessarily before the scan, but at least while you are scanning, you should. Because if the patient tells you that, yes, there is my previous child has had this particular problem, then even if I'm doing a scan at 30, 32 weeks and the earlier scans have been normal, I would try to look for that particular thing. From the history, I would also know that in the previous pregnancy, when did this particular abnormality that the patient is talking about, at what stage did it become apparent? And hence, the history is a very important thing that we need to take into consideration. Now, let me take you through two very important studies. Now, this is one study, where is a routine ultrasound in the third trimester. In this study, they saw cases which were scanned at the 11 to 14 weeks, at the 20 to 24 weeks, and then at the 28 to 32 weeks period. And they found out that 40% of all the anomalies were detected at the 11 to 14 week scan. 35% additional anomalies were detected in the second trimester, and 15% of anomalies were detected in the third trimester for the first time. So the overall detection rate was 90%, and also that 10% of the anomalies were detected postpartum. So that is also something that we need to be aware of. This is a 2020 study, value of the routine ultrasound examination at the 35 to 37 weeks gestation, and the total, this is 52,400 in pregnancy. The incidence of fetal anomalies was 1.9%. 67.7% of the anomalies were detected in the first and the second trimester, and a whooping 24.8% were detected for the first time in the 35 to 37 weeks growth scan period, and 7.4% were detected postnatally. So if you look at, there are so many studies where different systems, they've talked about what is the kind of anomalies that you would see later with a normal second trimester scan. And so this is in fact a reality. Now, when I'm looking at these figures, first of all, are coming from tertiary centers where the expertise has been very, very good. And secondly, these are all international studies where for them the second trimester is up to 24 weeks. So, for the world, the second trimester is 14 to 24 weeks. But for us in India, the second trimester is 14 to 20 weeks. Now, we are doing all our mid-trimester anomaly scan between the 18 to 20 weeks window period, and hence there is a possibility that a number of anomalies that would become apparent after that or in the third trimester would be much higher than what we are seeing in these international studies. So evolving anomalies, now they can either be evolving and progressing type, or they could be too late onset, or these could be anomalies which were not apparent on the earlier scan because of the small size of the fetus, or because maybe the sonographic penetration was not good, or then there could be missed anomalies which were missed in the second trimester, maybe because of lack of experience of the operator, or then the patient missed the 18 to 20 week scan window and they couldn't get a scan done then, and that is why you end up seeing this. So we are going to forget the fourth one. We will talk about these three sections today. And the common systems where you get evolving anomalies is the urinary tract, the GIT, the CNS, cardiac, and musculoskeletal. So progressing anomalies. Now these are anomalies which, these findings could be either very subtle at the 18 to 20 weeks period, or they could be absolutely normal. Now these are anomalies which have a natural history where they are known to progress, or they are known to remain static, they are known to resolve, but later on, so the finding could be very, very subtle at the time when you do your 18 to 20 week scan. But when the patient is either on a follow-up or comes for a growth scan, you may find that it has progressed into a significant anomaly, like ventriculomegaly. You may have a very, very mild, borderline ventriculomegaly at the 18 to 20 weeks period, but we know ventriculomegaly is known to progress. So in the third trimester, you would probably find that it has converted into an overt ventriculomegaly. So amongst the progressive ones, the most common thing is the urinary tract dilatation. Again, urinary tract dilatation has a natural history. Whatever pelviectasis or UTD that you see in the second trimester, we know that it can resolve, it can remain static, or it may progress. Sometimes it could progress from mild to severe. Sometimes you may have just hydronephrosis, and later on you may find that there is a hydroureter also, or there is a uretrocele. You may just find unilateral hydronephrosis, which may get converted into bilateral, and you may later on find that there is a distal urinary tract obstruction. a significant hydronephrosis may eventually get converted into cystic dysplasia or dysplastic kidneys, or at sometimes you may find that there is a rupture and you've got a urinoma. I'm not going to take you through too many pictures, but a few simple cases. 17 weeks, 3 days, everything looks normal here. Patient comes at 20 weeks, 3 days. There is mild unilateral pelviectasis, what we call about, that is 5.7 millimeter is the AP diameter of the renal pelvis. But when the patient comes at 37 weeks, there is a significant gross hydronephrosis with a ballooning of the pelvis, giving us an appearance of a typical, the pelvic obstruction. Then this is again 20 weeks, you have only hydronephrosis. 24 weeks, you are seeing a dilated ureter. So you're seeing hydroureter. And at 28 weeks, you find that the hydroureter, it's a significant hydroureter, and you're able to see a ureterocele also. So this is the progression that has taken place. And then this is 19 weeks, 4 days, unilateral hydronephrosis, definitely urinary tract dilatation, caliectasis. This patient comes at 26 weeks, and there you can see that this kidney has become a little more echogenic than normal. When you use a higher frequency transducer, you are seeing cortical cyst there. And at 31 weeks, you find that there are multiple cortical cysts that you're making out, the largest being 18 by 16 millimeter. So this kid from hydronephrosis or a simple urinary tract dilatation has gone into a dysplastic kidney. So this is the kind of progression which has happened, and this eventually has evolved. And of course, other GUT anomalies like ARPKD, the ADPKD, the ovarian cysts, you may not find at times in the second trimester, you may find it directly in the third trimester. The hydrocolpus, the hematocolpus would be again apparent in the third trimester. Then there are a lot of cardiac anomalies which are progressive. Especially is important is the great artery stenosis, and then coarctation of aorta, tetralogy of Fallot, because the pulmonary stenosis may not be as apparent at that time. You must see a small VSD and with a little override, and then a critical aortic stenosis may evolve into a hypoplastic left heart syndrome. For example, if you look at this case, this is 19 weeks, and ideally speaking, for somebody with a lesser expertise, they may just find this left ventricular outflow tract absolutely normal, and there's normal flow, no aliasing. But yes, with some experience, you may find that yes, there is a subtle post-valvular dilatation that you make here. And because of this small finding, and the velocities were now 97 centimeters per second, this was still normal. But you can't, this is a subtle finding, but I need to follow this patient up. This patient was called after 4 weeks, 23 weeks, you find that this dilatation has increased. The peak systolic velocity now has become 170 centimeters per second. The shape of the Doppler envelope has changed. You're finding that the acceleration to peak is almost at the mid-cycle there. All this is telling me that we are dealing with an aortic stenosis now. And slowly, you find that this is becoming from a mild aortic stenosis, it's converting into a severe aortic stenosis. Here you can see the post-stenotic dilatation is more significant now. You're finding that there is turbulence that you can make out in the dilated portion. And of course, the velocities have now gone to 309 centimeters per second. So this is the progression that has taken place. Now, there are certain anomalies which become apparent only in the late second or third trimester. Now, this happens for two reasons. One thing, that there is as I said, there is an embryological timetable. And for that, because the embryology tells us that, yes, these are the ones which actually form totally by 20-22 weeks. Things like, the sulcations in the gyrations, at what stage do you start seeing them? The corpus callosum, you may, of course, we know it gets completed by 18 to 20 weeks, but all the parts of the corpus callosum, we normally start looking after 22 weeks. So structures which are not fully formed, or sometimes the physiology prevents their early presentation, like the duodenum does not get cannulated early, and that is the reason you don't find a duodenal atresia at the 18 to 20 weeks, and then you find it later on in pregnancy. So among these, the most commonest are the GIT anomalies. All the GI obstructions, remember, right, starting from the esophageal atresias to the anal atresias and distal GI obstructions, are all apparent, in the late second trimester or the third trimester. And so they are basically the ones which we don't pick them up, and they're common things. These are very, very common anomalies. These are not very, very uncommon. And so we need to know this. Even diaphragmatic hernia, so at sometimes may present directly in the third trimester, or sometimes even after birth. A certain abdominal cysts may become apparent in the third trimester. Now look at this case, 19 weeks. Yes, there is a subtle finding that I was persistently finding that the stomach was a little small. The liquor was normal, but I can't label this as anything at this stage. Here. So the only option I have is to ask for a follow-up. The patient doesn't turn up for a follow-up, directly comes for 33 weeks, 5 days, and then there is hardly any stomach. There is polyhydramnios. I'm able to see the proximal esophageal pouch, and you can see the proximal esophageal pouch which is filling and emptying. And now I have a diagnosis to say that this is esophageal atresia. Whereas in the second trimester, I could not. And remember one thing, from this meta-analysis, the prenatal diagnosis of esophageal atresia remains very challenging. In the best of the centers, ranges from 24 to 32%. And hence, ultrasound is a poor diagnostic tool. This is coming from the meta-analysis. So these are all certain things we need to be aware of. We need to make people aware of also, because this is the most common thing I have found, that the patient ends up with, for the 18 to 20 week scan with someone else. They've reported as normal. Patient goes, because of a polyhydramnios, has been referred in the third trimester to someone else. And that stage he says this is esophageal atresia. And the next question immediately comes in, why was it not picked up at the time of the 18 to 20 week scan? Or maybe a loose comment from the second person saying, oh, did you not do an anomaly scan? That one simple question actually puts it in the patient's mind that no, this is something which should have been picked up at that stage. 18 weeks, 4 days, the stomach looks normal, nothing abnormal in this fetus. The patient comes at 24 weeks, and there you see a classical double bubble telling me, and communication between the two. There is polyhydramnios and telling me this is duodenal atresia. CNS anomalies, ventriculomegaly, of course, can be directly apparent only in the third trimester, or it can be a progressive kind. Microcephaly, ACC, and the agenesis of corpus callosum, and the partial ACC, Wormian hypoplasia, the Wormian abnormalities, the sulcation and gyration issues, the lysencephaly, destructive cerebral lesions, porencephaly, sesencephaly, hydranencephaly. These are all ones which become apparent in the third trimester. Look at this example, 18 weeks, you find that the head perimeter is, okay, it's at the 15th centile, no problem, dating scan was corresponding. I'm not worried about this. Now, this patient comes at 28 weeks, and I have the head perimeter which is at the -4 standard deviation below the mean. There is cerebellar hypoplasia, there is mild ventriculomegaly, I'm seeing a sloping forehead, everything telling me this is a microcephaly. So this was not something which was apparent earlier. Then the lysencephaly, the destructive cerebral lesions. I'm not going into the imaging part of all these, but yes, the porencephalies and the sesencephalies and the hydranencephalies would appear later on. Corpus callosum, it is, I don't say that, yes, complete agenesis of corpus callosum you can pick up at the 18 to 20 week scan. But again, because looking at the corpus callosum as such is not an integral part of any second trimester scan. We go by an indirect evidence, and that is by looking at the CSP. Now, the CSP is, recently I've seen people really taking CSP very seriously, but otherwise looking at the head used to be just taking the BPD and looking at the ventricles and the cerebellum. So, and then sometimes you find that the CSP is short, and sometimes you find that it is appearing very, very small, not very, very clear, and then you may just find that you're seeing some part of the corpus callosum there, but when this patient comes at 23, 24 weeks, that is the time you will be able to say that there is a partial agenesis of the corpus callosum. Then anomalies related to cerebellar wormis. You see increased fluid in the posterior fossa. You are seeing communication with the fourth ventricle. The BV angle is borderline, so this could just be a Blake's Pouch cyst. The worm appears okay. You may feel that this is a little smaller, borderline, but yes, you need to scan at 23, 24 weeks to come to a diagnosis there. Then there are certain anomalies which are too late onset. That is, they develop later in pregnancy only. This defects develop, or they could develop because of a particular maternal event, like there could be a maternal infection or a vascular insult, and this would lead to certain structural abnormalities, and so definitely you're going to find them later on. Majority of the tumors, wherever they are, would become evident in the third trimester, like the renal or the adrenal masses, adrenal hemorrhage, renal vein thrombosis can occur later on in the third trimester only. This is classical, where you see increased enlarged kidneys with linear branching calcifications. You can see a thrombus in the IVC also. Then late onset cardiac anomalies, your hypertrophic cardiomyopathy, ventricular aneurysms. We know that you can get premature ductal constriction because of NSAIDs or dark chocolates or certain food items, or application sometimes of the painkiller creams, or then cardiac tumors like rhabdomyoma. These are all things which you're going to pick up only in the third trimester. And if there has been an intraventricular hemorrhage, the sequelae of that, the intraventricular hemorrhage with periventricular extension, all these dirty looking ventricles and all, which you would see with hemorrhage. And in maternal infections, you may have a classical CMV fetopathy, periventricular calcifications in the parenchyma, calcifications in the liver. So this is something which has occurred later on because of the maternal infection which has taken place later on. Then vein of Galen malformation is another entity in from the CNS which you will be seeing, which becomes apparent only in the third trimester. Then all these neck masses, the goiters, the teratomas, the facial masses like the hemangiomas, these are all things that you see later on in pregnancy. So this is how we have gone about seeing how things evolve, which are the ones which become apparent later on. Certain things may become, they're present, but maybe it's because of poor sound penetration or because of the small size of the fetus, you're not able to make out at that stage. Sometimes you feel there is a unilateral renal agenesis, but when the patient comes to you later on in pregnancy, find that yes, no, there is a small pelvic kidney that is seen. Sometimes you feel just low placed kidneys. Later on, you find that there is a fusion between them. VSD, a very common thing that you pick up in the third trimester, where small VSDs, muscular VSDs may not be apparent because the gradient is not enough for even color to show you flow across that. So when you see in the third trimester, you are able to, especially the apical ones, you see better in the third trimester. The venous anomalies, total TAPVC, you can see in the second trimester. Most of the time you pick them up also. But again, with experience and all, you realize that, if you're not that experienced, and your machines are not, of a very high standard, your color settings are not well, you may end up missing them and they become apparent later on in pregnancy. Achondroplasia, again, one entity you should be aware of. You may have normal bone lengths within normal range in the second trimester. It is mainly a diagnosis in the third trimester. Milder forms of arthrogryposis or the fetal akinesia syndromes, the disease disorders, and these are the ones which you will see later on, and certain miscellaneous conditions like hydrops and hydrothorax. So this is one chart from the Palladini's book where he's given a list of anomalies which are always seen in the third trimester, which are seen in a significant number of cases in the third trimester. And then he's also seen that these are the ones which can be seen after birth also. So implications in clinical practice. Now there are 4 things that we need to think of. Genetic testing. Second trimester, easy. We know that yes, we can opt for a genetic testing. We can decide what testing we need to do. There would be probably be time enough for the reports to come down. Then second thing is management and outcomes, the thought process on termination of pregnancy after the 20 weeks period, and counseling. So we will quickly go through these points. Should a genetic testing be done? Yes. There are a lot of these evolving anomalies, right from your agenesis of corpus callosum to your ventriculomegaly and microcephaly. Lot of them have a genetic association, and hence it's important that we need to involve a genetist. Let them take a look, because genetics is not just about trisomy 21 or 18 and 13, and especially a lot of these anomalies which occur later on, especially the CNS ones. You have a lesion encephaly and you have picked it up later. Yes, you may have an absolutely normal 18, 13 and 21, but then you need to go for an exome. You need to find out whether you have the LIS1 or the LIS2 mutation, and that is why it's essential. And more important than that is to counsel the patient for the need of genetic testing. Most of the patients would say, okay, anyway, if we, whatever time the results come, we are not going to be able to do anything. Or anyway, you are saying there are so many anomalies in this baby is not going to do well. Why do you want genetic testing? The thing is that we need genetic testing because this is practically an index case, and we need to get this index case. Now, if these are anomalies which have evolved in the second or after the second trimester, in the third trimester, and if we know what is the genetic cause for that, in the next pregnancy, we could do a CVS or a testing much earlier and look for that particular gene. So we are not going to again wait in the next pregnancy till the third trimester for this phenotype to become apparent. So that is the reason today we have the phenotype, and so we need to promote DNA storage, because if the patient is not willing for too many things, do something basic, see to it that the DNA is stored, so that even if the patient undergoes a termination or after birth, find some other findings that you have not been able to pick up at this stage, that you have the DNA to look for, so you have a complete phenotype, then you can think and what is the genotype that you want to look for. Termination of pregnancy, of course, the legal limit for termination in India is 20 weeks. It is possible to terminate even after 20 weeks with permission of the court and medical boards. So 2 days back, we had an extensive session on this. And so remember, even for the medical board to give permission, there has to be a complete workup. So you just cannot give haphazard 2 points and say this is not looking normal or that is not looking normal, and then the patient goes to court and goes to a medical board. They're never going to give you permission for that. So even if you've gone for a genetic testing, if you get the reports, put everything together, and then or even subtle finding has been picked up, take a second opinion from an expert and see to it that they are able to add all other things into their report before the patient goes to a medical board or goes to court for that, and then guide the patient about this possibility. In Pune, you people are lucky, you have Chinmay Umarji and Dr. Datar. They are doing a wonderful work on this. So you can always consult them and take their opinion and send the patient to them so that they can guide them for that. And the outcome, the mode of delivery usually would be based only on the obstetric indications, but there are certain times you have a very gross hydrocephalus, or there is a situation where we know there is a trisomy 18 which has been diagnosed now, and so you would probably avoid a cesarean in those cases. What is important is that these are the ones who are not getting terminated because they have been picked up very late. These are the ones who are going to require postnatal management, and hence you need to involve the related specialists during the pregnancy itself. Involve the pediatric surgeons, the pediatric cardiologists, depending on the case, whatever you are dealing with, and then delivery in a tertiary center when necessary. Because suppose you are dealing with aortic stenosis, or you're dealing with a ductal dependent lesion, it is important that the baby delivers in a center where there is facility for pediatric cardiology, where they can start the baby on prostaglandins to keep the ductus arteriosus till the time they plan a surgery or necessary maneuvers that would be required to cure that particular disease. And lastly, this one question which the patient is going to come up to everyone. If I have picked it up in the third trimester, ask me, they're going to go to the obstetrician. The only question they're going to ask is, why was it not picked up earlier? You send them to a pediatrician, pediatric cardiologist, they're going to ask the same question there. So counseling becomes the most important thing here. We need to explain to them the concept of evolving anomalies. We should not criticize a colleague, very important thing. Everyone from the imaging specialist, the clinical obstetrician to the pediatric specialist, we all should speak the same language. And then only the patient is going to accept that, yes, this is something, here it is not the doctors who are responsible for this. This is something which has evolved over a period of time. This has unfortunately happened in my case, but he's not going to blame. I also say, whenever as an imaging person in a third trimester, if I see an anomaly, I don't ask the patient, have you got a second trimester scan done? I would go, just take their file and go and see, what was done before. Because if I ask them immediately, they feel that it should have been picked up at that stage. So these are certain small things that we need to take care so that we build patient confidence. We need to counsel them. We should not do a hurried counseling. Do spend adequate time with the patient. So to conclude, there are many anomalies which would evolve or become apparent in the third trimester. True late onset anomalies are seen only in the third trimester. Counseling parents about this possibility at the mid-trimester scan is important. So the problem is, patient comes, we do the scan, we give them the report, nobody talks anything, the patient goes to the obstetrician looks at the report, everything is normal. So nowhere is the patient informed that there is an evolving thing. All subtle findings in the second trimester scan should be documented. If there are subtle findings, you ask for a follow-up. If you're not very confident about your work, take a second opinion. And that is something which is also an important thing. Third trimester scans are not just growth scans. Looking for structural anomalies should be a part of every scan you do. So don't say, if the patient has come for a growth scan, BPD, HC, AC, fetal weight, Leica, Doppler, done, because the second trimester scan was normal. No, every scan that you do, looking for the structure should be a part of that. You may detect previously undetected structural anomalies which are relevant to the perinatal management and postnatal follow-up. Such diagnosis and subsequent management, including selection of timing and place for delivery and postnatal investigations, can potentially improve postnatal outcome. So even if at 37, 38 weeks, you have been able to pick up something, the outcome for that baby can improve drastically because the complete, the obstetrician is prepared, the related specialty people are prepared, and everything can be done immediately, whatever is required for the baby. There are still a few anomalies which would be diagnosed postnatally, and of course, we should be aware of that and we should make our patients aware of that. Thank you very much.
I must say.
Thank you, sir.
Yes, Dr.
Thank you, Bimal Sahani, sir. It was a really very good talk, and you really gave us a very good concluding remarks, and we'll definitely follow those. And in our private practice, it will definitely help us. Thank you, sir.
Thank you, madam. Thank you very much.
Thank you so much, Dr. Bimal, for the wonderful talk. Moving on to the next session, which is a panel discussion on the topic anomalies at 18 to 20 weeks. I would now like to invite our moderator, Dr. Aparna Sharma. The panelists, I would like to invite Dr. Reema Kumar Bhatt, Dr. Aparna Kulkarni, Dr. Chinmay Umarji, Dr. G.K. Lachan, Dr. Prakash Gambhir, Dr. Sachin Dagade, Dr. Santosh Sabnis, Dr. Sachin Nichite, Dr. Pramod Patil. Over to you, Dr. Aparna. May I please request you to unmute your lines?
Yes. Can you hear me now?
Yes, ma'am. Loud and clear.
Right. So, so let me begin by thanking the team POGS and especially Dr. Archana and Dr. Girija Wagh, who are the conveners of this workshop. And I have really an illustrious panel with me today. We have 9 panelists and we have 1 hour and 10 minutes. So there is a lot to discuss when you talk about anomalies at 20 weeks, the complete picture. But then, of course, we are at sea all the time. So the attempt today would be to understand the approach to anomalies. So when we talk about fetal anomalies, it is seen in 2 to 5% of the pregnancies and responsible for 21% of perinatal deaths. The outcomes and prognosis depends on the nature of abnormality, whether it is isolated, multiple, or a possible genetic etiology. And if it's an isolated fetal abnormality, the risk of chromosomal abnormality is low. But then if it is if there are multiple abnormalities, the risk of fetal chromosomal abnormality is high. Now, what are the questions that we need to ask when a patient comes to us or anomaly is diagnosed in the baby? First of all, the first and foremost question is it compatible with life? Are there associated abnormalities? Is genetic evaluation required? Is antenatal follow-up required? When and where to terminate? Mode of termination and postnatal evaluation. Now, these are some of the questions that do come to our mind, and we should make a protocol to ask ourselves these questions and answer them to the patient so that they are at a stage where they can decide. And all of this, we do agree that, you cannot do alone, I cannot do alone, and we do need a multidisciplinary approach, which would involve a basic obstetrician who's dealing with the patient, a radiologist or a fetal medicine person, and what happens after delivery, a pediatric surgeon, pediatrician, and pediatric cardiologist. So it's all about a multidisciplinary approach, and we do have a panel today who are radiologists, who are fetal medicine specialists, who are geneticists, although we are lacking pediatric surgeons or pediatricians. So I think through this illustrious panel today, we are going to understand and approach two cases. There is unlimited amount of information, unlimited amount of things that we can talk about. But through these 5 cases, we just attempt to understand what we need to do. So beginning with the case number 1, I would request Dr. Aparna Kulkarni and Dr. Reema Bhatt. So how we are planning is that, we are discussing one case with 2 experts so that, there is focused discussion, and then, we get to know the experience of each and every one. So I would like to start this question, the first case, with this image, and she came to us at 18 weeks and 6 days period of gestation. So request Dr. Aparna to tell us that, when you see this ultrasound findings, how would you actually try and understand the etiology? How do you want to arrive at a diagnosis?
Yeah, thank you, Aparna. And first of all, I would like to thank POGS for the opportunity for participating in this excellent panel. So when I see a baby at 18 weeks with that scan finding, can you go back? So what we can see here is the lateral ventricles are dilated. The measurement is 13 millimeters. So by definition, it comes under moderate ventriculomegaly. So when I see a mild to moderate ventriculomegaly, we have to have a stepwise approach when we start scanning. Of course, what we need to do is look at the shape of the skull, look for any associated abnormalities, whether it is only lateral ventricles that are dilated or whether there is associated dilatation of the 3rd or 4th ventricles, what's happening with the posterior fossa, what's happening with the anterior complex, is CSP present, is CSP visible, and so on. And once we've done, so the baby needs a detailed neurosonography. And along with that, I'll also need to look at the baby from head to toe to make sure that, or to find out whether baby has got any associated abnormalities in any other structures or any markers for aneuploidies.
Right. So as you have so rightly said that we need to look into the various associations with this abnormality, ventriculomegaly, the degree, and the other structures that we need to actually see in cases. So Dr. Reema, once you have done a detailed evaluation, and you what do you think about any genetic workup that would be required for a case of ventriculomegaly?
Thank you, Dr. Aparna. We need to understand that the risk of chromosomal abnormality is about 1.5 to 12% in isolated ventriculomegaly. This could be all the trisomies included, trisomy 9, 13, 18, 21, all could be present. The size of ventriculomegaly is inversely proportional to the association with the genetic abnormality. So we really need to be careful. Severe ventriculomegaly with obstructive, destructive lesions generally have a lower association. We also need to remember that there are a lot of syndromes that could be associated with ventriculomegaly, like the Miller-Dicker, the golden hair, the Meckel-Guber, and all the others, which have an association with ventriculomegaly. There is recurrent hydrocephalus where 3 to 4, and we had one such patient where there's association of L1 CAM gene mutation, which can lead to, it's an X-linked disorder with 50% chance of inheritance in a male child. Therefore, a genetic association is extremely important, but this is only after we've ruled out any infectious cause like cytomegalovirus and toxoplasma, which could be responsible for ventriculomegaly. So whenever we have a patient, we do offer an invasive testing, do a chromosomal microarray, and do DNA storage for all these patients.
Right. So thank you, Dr. Reema, for so nicely elaborating it. So Dr. Aparna, in this case, in this particular case, so there was no cause which was found out. So how would you go for an antenatal follow-up, and what would be the mode of delivery? You know, how would you go about it? So the follow-up of this patient.
So if it is a mild ventriculomegaly, and if we have done all the investigations which come back as normal, say the baby's got normal karyotype, no other associated CNS or structural abnormalities, then what we do is we suggest follow-up scans every 4 weeks, because CNS undergoes changes almost every month, and we need to make sure that a 24-weeker baby shows CNS findings which correspond to a 24-weeker. There are certain abnormalities which can present later on in gestation, especially the migrational disorders or lysencephaly, which at 18 weeks are very difficult to diagnose. So 4 weekly scans, and mode of delivery, if it is not a progressive ventriculomegaly, or if it doesn't progress into hydrocephalus, then the mode of delivery would be, it really depends upon the rest of the obstetric event of that pregnancy.
Right. So as you've correctly said, the follow-up would be required if it is an isolated, and as Dr. Bimal Sani just said, that there could be evolving lesions, there could be progressive lesions. So we need to look for those, and also the mode of delivery remains vaginal unless there is significant ventriculomegaly. So Dr. Reema, what is the postnatal prognosis of isolated ventriculomegaly? How would you answer? You know, this is a very important question that patients would ask, will something happen to my baby? What will happen to my baby? So Dr. Reema, what?
Yeah, so we need to tell our patient that ventriculomegaly is actually a common endpoint of various pathologies, and all of it with different prognosis. So if you have an isolated mild ventriculomegaly, the chances of neurodevelopmental delay will only be about 10%, which is almost equal to a general population. So we really need to tell the couple, please do not worry. But if severe ventriculomegaly is present, there is up to 60% chance of baby being abnormal, and the possibility of baby being alive would be about 80%. However, we need to know that early detection, progressive increase in ventriculomegaly, and known associated causative factors like X-linked hydrocephalus or any other cause definitely makes the prognosis worse. And therefore, all this needs to be told very categorically to the patients.
Right. So thank you, Dr. Reema. So, and I think all of this is what you said, that the IQ would, they do have a possibility depending on the cause and the severity of ventriculomegaly. So Dr. Aparna, then the patient definitely asks you, so what happens in the next pregnancy? So what is the risk of recurrence of such cases of ventriculomegaly?
Yeah, so the risk of recurrence, it really depends if we have found any cause or etiology for the ventriculomegaly. So if it is isolated, as your side is saying, the risk of recurrence is very small. If it is X-linked aqueductal stenosis, the risk of recurrence in a male fetus is almost is 50%. If it is infection related, there is no recurrence. It depends what the etiology is.
Right. So it is definitely related to etiology, and we have to find all possible techniques to find out an etiology. And if it is truly an isolated ventriculomegaly, the risk of recurrence is low. This particular patient actually had a Chiari-2 malformation, and she underwent MTP. So we could, so this was an easy diagnosis, but we do not always get such situations where we are able to offer a diagnosis in those cases. So if you want to answer those questions, is it compatible with life? So again, would depend on the reason. And if it is isolated, and as we have seen, they do have a chance of having a neurodevelopmental outcome which is close to normal. Are there associated anomalies? Yes, it is hugely associated with associated anomalies. Genetic evaluation required. Yes, as Dr. Reema said, that we need to do karyotype, and depending on the ultrasound findings, we might need to do a molecular testing also. Antenatal follow-up. yes, it would be required to look for progression. When and where to terminate, I think this is very important, that there is no need to do a preterm delivery. Mode of delivery remains vaginal if the BPD is normal, and postnatal evaluation and outcome depends on the cause and severity. So this is about the isolated ventriculomegaly, taken in a very simple way, but the idea is to understand that, the questions that we need to ask ourselves and counsel the patient. So thank you, Dr. Rima and Dr. Aparna, and we would invite your comments for the next of the case if you feel that you have a comment to make. So now we come to the next case. So for this, I would like to invite Dr. Sachin and Dr. Pramod Patil. So this is the finding that we find at 19 weeks and 4 days. So my first question would be to Dr. Sachin, that what is these ultrasound finding, and what are the other markers for prognostication and associated abnormalities?
First of all, there is a suspicion raised by a cystic structure exactly near the four-chamber view. So any cystic structure or a mixed echo texture structure lying around the four-chamber view should raise a suspicion of congenital diaphragmatic hernia, along with absence of stomach bubble, especially at the normal location. So if the suspicion of CDH is raised, then we should look for the contents of the herniation. So many of the time the common herniation contents are stomach, intestines, and the liver. That liver herniation is a major prognostic factor. So we have many modalities to diagnose actually whether the liver is herniated or not. One thing is to see liver directly, like a typical liver texture lying in thorax. If it is not very obvious, then the bowing of umbilical vein, or sometimes the newer recent UAG journal has put up a UVDA angle, which is around 21 degrees, is 100% specific for liver herniation. Sometimes we see the vessels, the hepatic vessels traversing towards the diaphragmatic edge. So liver herniation is one of the major prognostic factors. The another prognostication factors is the lung head ratio. Previously they used to use lung thorax ratio, but nowadays the LHR is more predictive. There are also some more varieties of LHR, that is observed to expected LHR and quantitative lung index. But even the LHR has a good specificity.
So would you like to kind of, tell us more about LHR and what values are the cutoff for LHRs?
LHR, if it is, it's a plain LHR, if you use less than 1 has a poor prognosis. If it is more than 1.4, it is a good prognosis. The values between 1 to 1.4 are the probable candidates for fetal therapy or postnatal repairs.
Right. So thank you, Dr. Sachin. So do you think that at this stage, if a patient comes to you, would you advise a termination? Because you are at a comfortable time period when you can advise termination of pregnancy. So for CDH, what else would you look at, as prognostic factors before you think about continuation of pregnancy or termination of pregnancy?
Apart from the contents of herniation, presence of other abnormalities is one of the major factor in deciding. So associated factors like CNS abnormalities, CVS abnormalities, limb abnormalities, which would probably suggest to single gene disorders, will decide my plan of action.
Right. So now we come to Dr. Pramod Patil, and so I would like to know what kind of a genetic workup would you think about in this patient, and I would like Dr. Prakash Gambhir, who is a geneticist on our panel, to also add on to what Dr. Pramod has to say. Dr. Pramod, please. Dr. Pramod, can you are you there? Can you unmute yourself? Dr.
Yes,
Prakash.
there.
Yes.
Dr. Pramod? Ma'am, he is unmuted, but he is not responding.
Dr. Pramod? Dr. Prakash, can you just begin this question?
Yeah. So basically, the question is whether any genetic workup is required, and it's definitely required because congenital diaphragmatic hernia many a times is associated with chromosomal abnormalities as well as single gene syndrome, has been just told by Dr. Sachin. So here we will like to have prenatal samples, tissue sample, and I will prefer it to be an amniocentesis sample because the chromosomal abnormalities that are there are either aneuploidies, most commonly associated aneuploidy here is trisomy 18 or trisomy 13 or Down syndrome, and along with that is the Killian syndrome where tetrasomy 12 is there, which is found only in fibroblasts. So it will not be found in a CBS sample, but it will be found in an amnio sample. This is about the chromosomal abnormalities. Again, here I would like to stress a point that here whenever prenatal sample is there, we want to look at the imbalanced DNA. So karyotype is actually also overruled by the microarray. So I like to have microarray for all the samples where we are going to look for chromosomal imbalances, because not only does it reveal all the abnormalities that are there with the karyotype, imbalanced ones, but it also has some microscopic detection of abnormalities. And don't forget to send the maternal sample along with your amniotic fluid sample, because it will take care of the maternal cell contamination. We have to rule out that because we want to make sure that the DNA that is there is of the fetal origin only and not of the maternal origin. So whenever we say, naturally we tend to say karyotyping, but please remember that we want to have microarray for all the samples where we want to look for chromosomal imbalances. So that is one thing, and has been said that with congenital other abnormalities that are associated with suggestive of a syndrome, or if your array is normal in case of multiple congenital abnormalities along with congenital diaphragmatic hernia, then I would like to have a whole exome sequencing so as to have a single gene diagnosis of that particular syndrome.
Right. So thank you so much, sir, for bringing out these 3 points. That yes, for a CDH we need to do a prenatal testing, genetic testing. And number 2, it is not just enough to do a karyotype. We need to look at the microarray because it is beyond aneuploidies also. And sir, as far as whole exome sequencing is concerned, so I think it is really the next step, and it really needs to be seen, and with a geneticist in picture, then how we can actually make it more useful. But yes, at least a karyotype and a microarray is something that needs to be done. So I would like to go back to Dr. Sachin again, and I hope Dr. Pramod Patil can unmute himself. That Dr. Sachin, just for the purpose of theoretical, because sometimes it is very fancy to talk about antenatal intervention. So can you talk about some antenatal intervention, and is antenatal follow-up required, like 18 to 20 weeks? You thought there is nothing else, it is isolated CDH, you've done a testing, and this patient wants to continue pregnancy. So how would you follow this patient up?
Basically, when we talk about antenatal therapy, the 2 options which are mostly talked about, one is in utero repair of diaphragmatic hernia, which did not give us a good success rates. Actually, the one which has a good success rate is Fetal, that is intratracheal balloon occlusion. So whatever modalities we use to occlude trachea, it has been shown that it leads to alveoli development or a fluid accumulation into the alveoli. Sometimes it pushes the organs also down as the lungs start developing. So that was the basis of using Fetal. Monitoring of CDH fetuses, suppose we plan that the fetus is not to be terminated. The prognostic factors we need to do surveillance about, that is LHR ratio, development of polyamnios, any other organs which are also included in the content of hernia, which will change the postnatal outcome. So every 4 weeks monitoring of fetal growth and these prognostication factors is important.
Right. So thank you, Dr. Sachin. And I think it's very important that if the patient is not terminating this pregnancy, the follow-up should be done. And we sometimes tend to, deliver them preterm or, try and take it out so that we feel that the baby will be better outside. But I think for malformations, which is very important, is do not add It's like an insult to injury. So do not add preterm risk to a patient, to a baby who's already malformed. So no point in delivering preterm. And an elective delivery or a planned delivery is important because the patient, the baby would need to be intubated immediately following a diagnosis of CDH. So this is very, very important. So Dr. Pramod Patil, can you please let us know, like, how is the prognosis of such babies, and, regarding the postnatal course, and how is the prognosis of a patient with CDH?
Ma'am, Dr. Pramod has just messaged me. He can't hear us.
Maybe he can just, disconnect and reconnect, because everybody else can hear. So I think there might be some network issue at his side. So I would request anybody if they can answer this question, or, Dr. Sachin yourself can answer this question. You need to unmute, Dr. Sachin.
Yeah. The postnatal course depends on the previously diagnosed prognostication factors. Of course, the content, suppose left lobe of liver or another content. Third, the facilities available for the neonatal treatment. So the course depends on these three factors majorly. If the facilities for exit and ECMO are available, the prognosis is good in isolated cases.
Hello.
If the liver herniation with chromosomal abnormalities, then the prognosis won't be that good.
Yes.
Definitely.
Yes, so definitely the prognosis depends on the associated abnormalities, the poor prognostic factors, what is the lung ratio. So all of this given. So now it has improved. The prognosis of these CDH babies have really improved. And depending on the cause, we can talk about the risk of recurrence. Dr. Sachin, what would be the risk of recurrence that we are thinking about?
Of course, if there are no associated chromosomal abnormalities, then there is no additional recurrence risk. If it is a part of trisomies, then it adds to 1% recurrence risk. And single gene disorders, definitely it's 25% recurrence risk.
Right. So thank you, Dr. Sachin. And I think CDH is one of the very common disorders that we do come across, and we are increasingly seeing that the outcomes can be better with good care, and whether there are associated anomalies or not. And as we discussed, genetic evaluation is required, antenatal follow-up if we are not terminating the pregnancy. It's very lucrative that we are at 18 to 20 weeks of gestation and we might offer termination rather than actually, who will take the headache of following it up, or maybe, after delivery, the baby will require surgery. So, but then, all said and done, it is up to the patients to decide when and where to terminate. It has to be at term, better not do a preterm, and mode of delivery remains vaginal, and cesarean is only for obstetric indication. Postnatal evaluation will require surgery, and if you have a good facility, the baby's outcome is good. So this baby delivered at 39 weeks, operated on day 2, extubated on day 4, and discharged on day 14. So it is not that, we cannot have a good outcome. It all depends on what is the prognostic factors, as we discussed. So thank you, Dr. Sachin, and I hope that Dr. Pramod can join us soon on this panel. And Dr. Pramod, as soon as you do join, I would request the organizers to let us know so that, he has joined, so that we can involve him and direct some questions towards him. So for the case 3 now, I would invite Dr. Lachian and Chinmay for this case. So this particular patient, she presented at 19 weeks again, and with this finding. So this is the finding that we had at 19 weeks of gestation. So I would request Dr. Lachian to tell us that, what do you think about these ultrasound findings, and, how would you differentiate it from its most common differential diagnosis?
Well, thank you. The findings are very clear and staring, but for the benefit of the junior colleagues I described, there is a midline defect from the base of umbilicus, and as we can see, there are bowel loops floating inside. Most important is there is a covering membrane over that. As you can see, it's a nice covering membrane, and color Doppler is showing the umbilical vessels passing through it. So it is at the entry is at the apex, and it passes through it. There is I'm not too convinced, but doesn't look like any liver inside the sac. So that is very important. Now the two most important differential I would consider. Yeah, okay, fine. If it is high, it may contain heart. If it is low, it can lead to cloacal abnormality and spina bifida. So we must definitely give sufficient attention to the contents, and then probably we can go ahead with detailed scan also. Now, most important, as we said, this 11 to 13 weeks business is most important. The physiological, will not go into details of embryology, but at 6 weeks there is physiological herniation. It starts, and by 12 weeks most of the intestine goes back to the abdomen. So any diagnosis of omphalocele before 12 weeks is very important. Hold it. Don't disclose it. You can, if it is really gross, you can definitely say, okay, I can definitely suspect, but don't jump and say, oh, this is omphalocele. So always call the patient back at 13 weeks or 14 weeks, and then you can say, okay, this is a case of omphalocele.
Right.
Now,
so thank you so much. Yes, sir, please.
No, I think the next one, Chinmay is waiting.
So, no, sir, and I think this point is so good that, day before yesterday, we saw a patient at 10 weeks and, we were, my colleagues were so excited about, it being an omphalocele that we diagnosed at 10 weeks. So this is what we said that, okay, let us not give a diagnosis or sound a death knell to the parents that, something is wrong. So we called them back after 2 weeks that let's see what is happening. So I think that's a great point, and you've really, elaborated those points well. So Chinmay, what are the associated anomalies with omphalocele, and what do you want to talk about this here?
So unlike gastroschisis, omphalocele is that way a concerning diagnosis because it has huge association with chromosomal and genetic syndromes. As many as half of the babies may have some aneuploidies associated with them, like with Weidman syndrome or other rarer syndromes associated with them. Also, there could be multiple defects, especially the heart defects. So, as your slide says over here now, and that's the reason why you want to have a thorough genetic sonogram. Also, you want to have a genetic diagnosis on these babies. And once you have ruled out the diagnosis, then you can, you have ruled out the aneuploidies, then you can counsel the patient accordingly.
Right. So, doctor, I would like to talk about the investigation plan for this patient and how would you follow it up. So, I would like to ask this from Dr. Lachan, and I would also like Dr. Gambhir to, comment about it.
Okay, one small thing I wanted to add, Aparna, is the second differential, which is really important, that is gastroschisis. So the main differentiating feature from omphalocele is in gastroschisis, the defect is off midline, usually to the right side. Okay, and there is no covering membrane. And why it is important to differentiate is because omphalocele has worse prognosis. There are many chromosomal anomalies associated, structural anomalies associated, cardiac anomalies associated, whereas usually in gastroschisis, the prognosis is much better. So there are less of the other anomalies associated. At the most, there can be local problems like bowel strictures also, which can be tackled easily. So that was first part. Number two is the investigation. The next investigation is ultrasound again. Why? Because when you diagnose something which is very, staring at you, it is easier to label and forget about it. Okay, but what is most important is to have a relook. So if there are 10 patients waiting outside, you tell the patient that, okay, I have seen something and I really want you to come back and I want to see everything in detail. So that is most important. And then you have a detailed ultrasound for structural anomalies, for soft markers, and additionally, you should do a fetal echocardiography because cardiac anomalies are very, very common with that. And if you are not really very well versed, then probably you can refer the patient to, there should not be any ego issues in that. And I think you should refer to a higher center where everything will be available under one.
Right, sir. Thank you, sir. And I think it's very, very important, because we just try to label the fetus at the first thing that we find, and we actually don't call the patient by the name but by the diagnosis of the fetus, and it is such a common thing. But what you've said is really important, that please ask the patient to wait, come back, do the scan in detail again. So I would like to request Dr. Prakash Gambhir to tell us about the genetic part of omphalocele, and what is the test that you would like to advise.
There are two components of genetic diagnosis are there. The one is the chromosomal imbalance in the form of aneuploidies. Again, like I said last time, it should be with the help of microarrays. And second is the Beckwith Wiedemann, which is prominently associated with omphalocele. So that is the other things, which is the imprinting disorder. So methylation sensitive molecular mechanisms have to be elucidated. So that is why we require a special investigation for Beckwith Wiedemann syndrome. So these two things are the main things. The mainstay of the genetic diagnosis in preface of omphalocele.
Right. So thank you, sir. And I think the repeated theme that is coming up is that when we have malformation, we need a microarray. So I think that is thing, that even if it is associated, known association with aneuploidy, you need to look more than just karyotype, and you look for the malformation. Now, what would be the plan for delivery, Dr. Chinmay, and how is the prognosis going to be?
So this baby in whom all the aneuploidies and syndromes have been ruled out still may have some surprises. So of course they need tertiary care, they need multidisciplinary. So you'll need NICU because they may have lung issues. You'll need a pediatric surgeon standby. So you have to deliver them at a tertiary, rather a quaternary care center where all of these facilities are available. Also, mind you, many of these babies may have fetal growth restriction, so sometimes they may need premature delivery. It's very tempting to offer a cesarean to these babies because there are so many bowel loops out there. But it's also important to protect her obstetric history, because obstetric future, because usually these are younger mothers. So it's very, very important that you offer vaginal birth and reserve cesarean only for obstetric indications, or if omphalocele sac is really big, say it contains liver, then you should kind of offer a cesarean for them.
And what is the prognosis that you would talk about? Like, what will you tell the parents that, okay, this is an isolated omphalocele, there is nothing else which has come out, and we are going to deliver you. So how the baby is going to be?
They would usually do very well. So this success rate, like not as good as gastroschisis. Say gastroschisis would have more than 90% success. Here you should be looking at 70-80% with isolated omphalocele.
Right. So I think that's a great point to bring about, that gastroschisis has a better prognosis as compared to omphalocele, because whatever you say, there might be some associations with the other defects. And also, most importantly, what you said is that, omphalocele is something that is right there on the abdomen. So we think, and we would be probably tempted to do a cesarean section, but it is possible to offer a vaginal delivery unless it's a very giant liver which is outside. So just to conclude this topic, is it compatibility with life? So if it is isolated and you've reasonably, ruled out other problems, it has a good outcome. Associated anomalies, yes, there are a huge amount of aneuploidies and syndromic association, and genetic evaluation is required. Antenatal follow-up is required if the pregnancy is being continued, and it should be terminated as close to term as possible, with vaginal delivery being an option, and postnatally the surgery would be required. So I think, and this particular patient actually, she was within the 18 to 20 weeks window, and she underwent a termination of pregnancy. Although we did do a karyotype and a microarray, we did offer her, but after the testing, she underwent a termination of pregnancy. So I think 18 to 20 week scan is something that is there, to offer, a possibility of termination also, if we think that the parents are not ready to take that kind of a risk. So thank you. And now we will go on to the next case. And for this, I would like to invite Dr. Sachin and Dr. Santosh. She's again a 32-year-old lady who came at 19 weeks with this, terrible findings on ultrasound. So I would like to request Dr. Santosh, how do you describe what are the other things that you want to look at?
Good evening. Thanks a lot, POGS, for inviting me. Can you see me?
We can hear you. Dr. Santosh.
You can hear me?
Now we can see you. Yes, we can see you. Yes.
Yeah, sorry. So thanks a lot, POGS for giving me this chance. And as far as this case is concerned, and can you go to the video, please? Yeah, okay. Okay, so what you see here is a grossly dilated urinary bladder, and apart from that, there is a dilatation of the urethra as well. And on this side, you can see some dilatation of the kidneys, which is gross on both sides. So we have gross heteronephrosis, which is bilateral, and we have a usually distended bladder and a usually dilated posterior urethra as well.
Right. So what is the other things that you want to look at this stage? What are the any other thing that you want to look at which would be very important for prognostication?
Correct. So the most important condition that warrants attention is the presence of LICA. If there is oligohydramnias, then it will go in a bad prognosis. It will have a bad prognosis. The largest pocket, less than 2 centimeter, will have a bad prognosis. It should be looked for in this condition. As also the nature of the kidneys. You want to look for the echogenicity of the kidneys and see if there is any findings of renal dysplasia. See if there are any subcortical cysts present in the kidneys. See if the renal echogenicity is increased or not, and look for the LICA. I think these are the most important prognosticating factors.
Exactly. So Dr. Santosh, thank you. And I think those are the LICA is one of the very important thing that would determine how the baby. So we generally follow this rule that if there is anhydramnios before 20 weeks, then anyways there is not much of a scope for the baby. So I mean that is one very, very important sign that we have to look at. So interestingly, I just want to point out one more case here where again the kidneys looked echogenic, there was bladder distension. Along with that, there was a urinary ascites also.
Right.
So this is another extreme manifestation where there is a rupture of the urinary bladder and there is extreme obstruction. So Dr. Santosh, sorry, Dr. Sachin. Dr. Sachin, are you joined now here? Dr. Sachin, I can see, I cannot see.
Yes, ma'am, I'm there.
Dr. Sachin Dagade. Dr. Sachin, Dr. Sachin Dagade, have you joined with us? If not, can Dr. Pramod join us on this? Rather, I mean, this is one of the common situations that we do come across. Or Dr. Santosh, can you just continue with this?
Yeah, sure.
So, do you think that the PUV is, or the bladder outlet obstruction, are there associated abnormalities with this particular situation very common or not?
They are not very common, madam. Other than the renal abnormalities, associating findings disease are not there. The problem with it is presence of oligohydramnias, which may cause abnormalities like portophases or presence of club foot or club hand, and associated abnormalities because of oligohydramnias like lung hypoplasia and so on. So they are common with these conditions, but otherwise, as such, association with PU walls proper is not so common.
Right. So yes, thank you so much. So for the genetic workup, can Dr. Sachin Dagade has he joined, or maybe we can just
No, ma'am, he isn't joined.
Okay, great. So thank you so much. So we can request Dr. Prakash Gambhir. He's our geneticist for the panel today, so he can give. We request him to give his input on this particular situation also.
Basically, this is a common abnormality in males. Second thing is that 10 to 15% of them may be associated with chromosomal abnormalities. So again, here we will have a chromosomal workup, as you said, preferably with microarray. So we can have that.
Right. So I think blindly, at least for the purpose of practice, we can say that if there's an abnormality, let's go ahead and do some workup and microarray preferably, because you need to rule out the associations with chromosomal abnormalities as well. So Dr. Santosh, we will come back to you. That is antenatal follow-up. So suppose this patient anyway is an extreme case and she actually opted for termination of pregnancy. But in cases of PUV, like, if it is not very, and at 18 weeks you have diagnosed the PUV, how would you follow up these patients, and is there an option for antenatal therapy?
Right, ma'am. So follow-up is essential in such mild to moderate cases. If the case, as you showed, it's very severe, then is no point in continuing. But if the symptoms, if the signs are not very severe, if there is mild to moderate findings, then we can definitely follow up. Once in every month or every 4 weeks, follow-up is necessary till at least 28 to 30 weeks. This is to look for all those prognosticating factors that we look for. Presence of anhydramnios or oligohydramnios, presence of renal increased echogenicity, signs of renal dysplasia, and this all should be looked up till at least 30 weeks. And then after 30 weeks, you should follow it up every 15 days or so till around say 32 to 33 weeks. By that time, we can decide, we can take a decision about termination, the delivery of the patient, delivery of the fetus, and by that hopefully lung maturity would have come. And as far as fetal intervention is concerned, till 24 to 34 weeks is the window for fetal intervention. There are some specific criteria. If they are getting fulfilled, then only we can try fetal intervention. And in a normal liker, fetal interventions are not needed. But the whole idea of fetal intervention is to essentially give the fetus a good liker and help the lung maturity. That is the primary requisite. And for that, various ways have been tried. The two most common fetal intervention techniques are the vesicoamniotic shunt and the fetal and fetoscopic ablation of the posterior urethral valve. The idea is, again, the distended bladder should be emptied and the amniotic fluid should increase, and so as to give supporting environment for the lungs to mature. However, it has been proven that it does not help per se the prognosis of this case, and it may just give an increased liker and a false sense of security, but the prognosis essentially does not improve. As far as ablation, fetoscopic ablation of the valve is concerned, it has a large incidence of mortality and morbidity. And again, the prognosis is not very favorable even after these interventional procedures. So it has to be explained to the patient and then taken into this consideration whether we can go ahead with this.
Right. So thank you, Dr. Santosh. And actually, we were very enthusiastic few years back, putting shunts in every patient, and going in for those interventions. But with repeated trials, with repeated studies, which have shown that it's not very, very effective in terms of outcome, and maybe the fulguration, fetoscopic fulguration intrauterine might be, better than just putting a shunt. But yes, it has to be decided on a case-to-case basis. So, Dr. Santosh, what is the postnatal prognosis of such cases, and do they do well? Do they, how do they do postnatally?
Even though with such technical advances, and even though we have been diagnosing them earlier, the prognosis has not been very favorable. And a long-term prognosis is obviously not very good. Short-term prognosis, as with severe oligohydramnios and anhydramnios, there is neonatal demises and poor prognosis in general. And long-term survival and long-term follow-ups have been done, and around 50% of them will land in chronic renal disease. Around 37 to 38% will have end-stage renal disease. 20 to 30% will have long-term hypertension and chronic renal failure, and so on. So essentially, a severe form of this will not have a good prognosis. So all this should be counseled to the patient at the proper window, say 18 to 20 weeks. So it's a good thing that if we pick up such a finding, then a proper counseling be done and the pregnancy be terminated.
Yes, so thank you so much, sir. And I think this is a very, very important point, that when 18 to 20 weeks, when we are evaluating, and liker remains one very important aspect to see whether the liker is getting reduced or not. And there is a fine window where we think that the babies might do well. So one is an extreme form where we need to terminate the pregnancy. Other is a very mild form, which is possibly, you rule out the aneuploidies and all of the tests which are done. But in between, where there is this slight oligohydramnios which is setting in and there is an increasing compression, that is the window where we can consider an intervention, and yet we do not know how the outcome is going to be. So interestingly, for this patient, the second patient which I showed, who had the urinary perforation and urinary ascites with bilateral hydronephrosis. So the sighting tapping was done under ultrasound and straw colored fluid was aspirated. She was on continuous follow-up with us. And then cesarean was done at 34 weeks after steroid cover. And cystoscopic fulguration of the PUV walls were done. Renal cortical scan done 7 weeks after the birth showed slightly impaired function in the right kidney. So one kidney was functioning properly, and at 1 year of age, the baby is doing fine. So, there is this mild window where we can think about intervention, where we can think about follow-up. But if there is no liker before 20 weeks, then possibly the outcome is dismal. So this is something that we need to remember with PUVs and lower urinary tract obstruction. So is it compatible with life? Poor prognosis if there is severe oligohydramnios. Potter sequence is the most commonly associated anomalies. Genetic evaluation, microarray for all of these cases. Antenatal follow-up, if the pregnancy is continued, we have to keep looking for the antenatal follow-up. Termination of pregnancy is possibly late preterm. You don't want a worsening bladder function if you know that this is a progressive disorder. Termination mode, again vaginal, no need to do a cesarean section, and fulguration in the postnatal period if the renal function is maintained does give you a guarded prognosis. So thank you, Dr. Santosh. You had to answer all of these questions, and thank you, Dr. Gambhir, again for your inputs in this case. So now we come to the last case, and I think we are maintaining well in time. We started, so we have around 12 to 13 minutes to go. So now this particular case is this patient, she had come with short femur. So I think this is one of the, so I've just included this 21 weeker because she had just come at 21 weeks. But this short femur thing is a nightmare for all of us. They just refer from anywhere saying short femur, and then you are at a loggerhead to understand what short femur, how to go about it. So I request Chinmay to talk about a short femur, how to, really think on lines of what it is.
Yes, ma'am. So I can relate to the nightmare, and what I start thinking on the lines of is whether I'm dealing with wrong dates, hopefully. If it is not the wrong dates, and if I don't have any previous scans to compare with, then I would like to look at the biometry of this baby. So look at BPD, HC, AC, and all the long bones. So I would like to look at the structure of the bones, and not only the long bones, but the entire skeleton really. So understand if the limbs are comparable to each other, and if the limbs are comparable to gestational age, which is say seen by HC and AC. Also the mineralization, shape of the bones, the diameters of the thorax, and also the skull and the profile. Because what I'm thinking over here is A, aneuploidies, B, infections, C, dysplasias, and all of them appearing so early in the pregnancy will have very guarded prognosis. And ultimately, it could be fetal growth restriction, which sometimes may have slightly better prognosis than these tissues.
Yes, so I think this is, so what happened in this case is that this baby had all the bones which were short, so that is tibia, fibula, and the femur, and the ulna, the radius, and so it was like more of a rhizomelic shortening. The radius was really, really small, and and then if you look at the thoracic contour here, so there is this shortening of the thorax as compared to the abdomen. And then, Chinmay, would you like to talk about the lethality, and the foot length also has been taken, which is around 2.8 here, which is shorter than the femur.
Sure.
So a bit about the lethality and, why it is important to look for lethality.
So basically what is happening over here is there is this rigid skeleton which is going to restrict the growth of soft tissues. Because soft tissues, mainly lung and heart, are encaged by the rib cage, they are not able to expand. These babies cannot breathe after delivery. And because they cannot breathe, it becomes really lethal to them. And there are few signs which you can look for on a scan when you are talking about this. So as you rightly mentioned, ma'am, rhizomelia would be a bad sign. If foot length is more than that of the femur, again, that will be a bad sign. Also, you want to look at the mineralization if there are fractures anywhere, if there is frontal bossing, and all of these appearing at an early age of say 21 weeks are associated with lethal dysplasias. So these are the babies who will not benefit from continuing further, and that will just increase the obstetric risks and poor outcomes for the mother. So it is very, very crucial to try and assess lethality as early as possible. And if you understand that it's a lethal dysplasia, you want to identify the genetic associations, if there are any family histories, if there are any chances of recurrence in the future pregnancy, and maybe offer termination in safe time.
Right. So thank you, Chinmay. And I think I would like to just say that, Chinmay said first thing that he would wish that it was wrong dates. So I think that is the first thing that we need to understand, that the dating is correct. And if we have ruled out growth restriction, that even the abdominal circumference is small. So these are the two things that can happen. The third would obviously be constitutional, that the mother is small, the baby is small. So it is nothing else, but it is just a baby who's growing small. But if we actually think that it is skeletal dysplasia, like in this case, all the long bones were small. So I think there are two things that we really have to reiterate, that is it lethal or is it non-lethal? Because, you know, suddenly offhand by just doing one ultrasound, you might not be able to come to a diagnosis. But what you can understand, what you can determine is it lethal or is it non-lethal? Because anything which is coming at 18 to 20 weeks and you think that it's a lethal skeletal dysplasia, you would think of termination of pregnancy. So I think the condition of lethality is something that we can determine on ultrasound. So something like a chest circumference which is less than 5th centile, the ribs are short, and then FL to abdominal circumference ratio. So these are certain ratios that need to be done in all cases of skeletal dysplasia. And another very important picture that we showed here was of a foot length. Because even if the baby has skeletal dysplasia, the length of the foot will remain normal. And as a, you know, a blank guide, we have to have that the foot length and the femur length are generally the same in every baby. So if the femur length is small and the foot length is big, then we know that, okay, this is skeletal dysplasia. So if it is a ratio which is less than 0.9, then we know that there is a problem and it is a skeletal dysplasia. And if we have to look for the most common lethal skeletal dysplasias, why? Because these are the situations where you would want to terminate pregnancy, definitely. The rest you cannot determine. So important thing is to look for mineralization, fracture, a macrocranium, and the trunk. So if you are looking at all of these things on an ultrasound, I think it will make a huge diagnosis, a huge difference on the diagnosis of skeletal dysplasia. So, sir, again, coming back to Dr. Prakash Gambhir, sir, I think skeletal dysplasia is one of the most difficult genetic diagnoses to make. There are more than 400 or 500 cases which can result in a particular phenotype. So, sir, how would you suggest the genetic diagnosis of a skeletal dysplasia?
So basically, this is rather easy problem because usually here you have got a lethal type of skeletal dysplasia. So as Chinmay said and you said, the nightmare really is not there because the decision is already there. But it is important here to have a look at the fetus after fetus is being terminated, because then you get the clinical clues after looking at the fetus as well as having the x-rays of the fetus regarding the type of skeletal dysplasia that is there, because this is very important from genotype-phenotype correlation. Especially, as you said, there are more than 450 types of skeletal dysplasias, out of which 350 have got known gene. So many of them don't have any known gene also. So we want to know what is really happening with the fetus. So that is why we want to document everything. That is one thing with the x-rays and the skeletal abnormality that we get, as well as we want to have a focused panel if we are looking at a known entity or a whole exome sequencing in case we are having some unknown problem. And then whatever the DNA mutations that we get, whether the really pathogenic mutations they have been present in the previous patient, reported in the previous patients, or their VOU says, then we have to have the parental mutation matching also, so as to have the significance of this particular changes. And this is especially important because here we are getting a sonographic diagnosis at around 21 weeks. So if we can actually molecular diagnosis of the fetus, then we will be able to give them prenatal diagnosis in time at around 16 weeks of pregnancy. And then this pregnancy has not, affected pregnancy will not be carried so far. So that is very important from a skeletal dysplasia point of view.
Right, sir. Thank you, sir. And I think that's great. So, sir I said it is a nightmare. Sir said it is so easy. See, the difference is that, you know, once you have a diagnosis of lethality, so first thing in a skeletal dysplasia, make sure that it is not aneuploidy, it is not fetal growth restriction, it is skeletal dysplasia. And if it is lethal, then your work is simple, unfortunately, but the work at least is simple, that you offer termination and then you evaluate the baby in conjunction with the geneticist and look for the mutations. But if it is not a lethal skeletal dysplasia, then what would you do? So I think sir has already talked about it, that you know, it is a bit complicated, that if it is an ongoing pregnancy, because molecular testing takes time, so maybe you might not have, your pregnancy is being continued, so you might not have time to do that molecular testing. But if it is a known condition and the fetus is at risk, then you have the specific molecular testing which can be done. And if there is a prior affected fetus, and then it is not something, it's an autosomal dominant and it doesn't recur, so then in that case again the genetic testing would be difficult. But if both the parents are carriers, then again there is a role of testing for the fetus. So although this particular patient had lethal skeletal dysplasia, so Chinmay, the nightmare for us continues that it is a non-lethal, or how do you manage this pregnancy and postpartum?
So, ma'am, I'd like to counsel the couple that this is not just another pregnancy, and they need to really have very regular follow-ups, and they'll need to see multiple people will be offering multiple investigations to them. So we may want to repeat our ultrasounds. We may want higher investigations like say MRI. Also, a routine amniocentesis with just a microarray may not help here. So we'll need a clinical exome or ideally whole exome sequencing in these babies. After the diagnosis is kind of reached, then they need to start seeing the post-natal care. So they want to see the neonatologist, they want to see orthopedic surgeons, and understand how the course is going to be and how near normal life can be achieved for these babies, especially during schooling, etc. I would like to kind of offer them repeat ultrasound examinations, understand on what centiles the baby is growing. And again, as the dictum goes, cesarean should be reserved only for obstetric indications. So unless the fetal skull really grows big, which is macrocrania, we would reserve this only for that. Cesarean will be reserved, and for everybody else, a vaginal birth should be offered.
Right. So this particular patient, we terminated the pregnancy and the whole exome sequencing was done, and infantogram, as Dr. Prakash Gambhir suggested that we should do. And so it was suggestive of the typically pathogenic variant of a thanatophoric dysplasia. So I think we could achieve a diagnosis in this particular case, but it is not really possible in a lot of cases. So, and again, I would like to reiterate that recently we had another patient who had skeletal dysplasia and a previous to cesarean section. So we do end up, having, so again and again, the point of saying is that do not do a cesarean section, do not go for a cesarean section, is because we have increasingly number of women who are coming with malformations and with previous to cesarean section. So we do end up doing a cesarean for a malformed baby. So I think those are certain points which we'd like to again, stress upon. So is it compatible with life? Look for lethality. I think that is one most important thing that we need to understand. Are there associated abnormalities? Yes, if there's syndromic, other facial, GI abnormalities, there could be polyhydramnios. Genetic evaluation, yes, I think here is a case where you need to really cooperate and take help from your geneticist friends. And antenatal follow-up, yes, if the pregnancy is continued, we need to see how, sometimes, it is isolated, there is no other problem, the fetus is on the fifth, femur length is on the 5th centile, continues on that trajectory, so that can be a possibility. Macrocrania, yes, because that will tell you whether she can undergo a vaginal delivery or not. When and where to terminate, again, it should be taken up to term as much as possible, and specifically that no preterm delivery should be offered to her. If the pregnancy is terminated or the baby unfortunately has an IUD or a stillbirth, fetal autopsy is something that should be done along with molecular testing. So with this, I think we do come to an end of our 5 case discussion. So what I would like to reiterate again is I am really sorry that we could not get Dr. Patil, sir. Have you joined now? Can you hear us?
No, ma'am.
Okay. So I would like to say that management of congenital malformations is a multidisciplinary management. You have to differentiate between soft markers and structural markers. Genetic evaluation is required. Antenatal counseling is the most important part, because we do have patients who come to us and they say that bachche mein koi kharabi nahi thi. We were not told about anything, as Dr. Bimal Sani just said. And decide the place and mode of delivery. So we do have 5 minutes. So I would like to invite one final comment from each of our panelists on, how on one point that they would like to stress when they are managing patients with congenital malformations. Let us start with Dr. Aparna Kulkarni. Or I think ma'am probably is not there. So Dr. Reema, ma'am, Dr. Reema, what would you like to just say as a final comment?
So Dr. Aparna, I would agree with what Dr. Prakash said. We have changed over to chromosomal microarray with ultrasound, and our diagnostic definitely better. We're picking up more abnormalities and we're able to prognosticate the future pregnancies. So this is one point that, we need to actually change over to chromosomal microarray and not just karyotyping. That is what I want to bring about here.
I think that's a very, very important point. So thank you, Dr. Reema. And Dr. Aparna ma'am, have you joined? Dr. Aparna Kulkarni?
Yes, ma'am. She is there.
Yes. So we are just concluding with one final remark from all of us. So what would you like to say regarding one important thing about the management of malformations that you come across?
Dr. Aparna, please.
Yes.
Aparna, may I please request you to unmute your line?
Ma'am, she is not responding.
Okay. So Dr. Sachin, can we have your final comment, please, Dr. Sachin?
What I feel is the importance of a thorough ultrasound examination with appropriate knowledge, so that we can counsel the patient better, and we should know the impact of each ultrasound parameter on the outcome. It's very important. Not just doing ultrasound and this fetus cannot survive and go for termination and there is no future to the baby. Like this, things should change gradually.
Right. So I think very important that, we need to go into the depth of the problem and assess completely and not just label with one anomaly which is present.
Yes.
So thank you, Dr. Sachin. Now, Chinmay, can you talk about your final comment?
Ma'am, many thanks for the opportunity and such a lovely discussion. Thanks, POGS, for taking us in. What I would love to understand, rather, ma'am, from you is this confusion about the new bill which is coming in. And you have been instrumental, as we know, in getting it, cleared and, framed, and then now they've cleared it in Lok Sabha. But is that bill still a law, and how are we placed right now if we have to terminate that 21-weeker with lethal skeletal dysplasia?
Yes. So I think me and Chinmay, we have really, kind of interacted on this aspect a lot. And I would agree that, 20 to 24, it is still 20 weeks. I would say that, it is still 20 weeks, but we don't stop doing terminations because, she's 21 weeks or 22 weeks. So we will wait for one Rajya Sabha session for the bill to pass. And believe me, that bill is so good. Once it becomes termination of pregnancy. So up to 24, you don't need anything. Beyond 24, you need a medical board. So I think once the bill is in place, our lives will be so much more simpler. But till then, we are still approaching the courts. Even just yesterday, we had a patient and we advised her. She had a occipital encephalocele huge. So we told her, we will help you connect with the lawyers, and within a week, we'll file a case for you. And the courts do cooperate. So it is a possibility. So till the bill becomes a law, please approach the court. Not just because it is floating, it is almost there, it is there in spirit. You cannot really say that, okay, now I will terminate 21 weeks without a court order. We are not doing that. We will not advocate it till it becomes a law. But then we need to help our patients, and we need to make them understand that, yes, there is an option and we should go ahead and do it. So I think that is, so you have asked the questions back to me. So thank you, Chinmay. And with that, we will go to Dr. Lachian, please.
Yeah, thank you, ma'am. Basically, I want to stress one thing, that we all, like radiologists, fetal medicine, geneticists, we are neonatologists, and most important is obstetrician. And the patient, we should be on one side. We should talk the same language. Because many times the problem arises because of, the casual, like somebody, I think Bimal told about it, is casual comments. And then the person who's suffering, you will not understand what kind of suffering it is. So I really feel like we should make our colleagues aware about all the problems. And we should take the patient on our side also. And yes, then disclose, whatever we should discuss among ourselves, because before we disclose anything to the patient, rather than talking loosely. That is my sincere request.
Right. So I think, sir, that is a very, very important comment. A loose comment like "pehle nahi dekha tha kya." So something like that devastates the patient like anything. So, and I think we have to be on the same page as the patient and as somebody who's referring the patient to you. And before we disclose anything to the patient, we need to understand what we are going to say. So thank you, sir, for bringing that part up. And now I would request Dr. Santosh and then Dr. Prakash to tell us one final comment. Dr. Santosh, are you there? Dr. Prakash, we can take your comment, please.
Yeah, I suggest that we study all our terminated fetuses, because many studies have shown that additional findings are seen in 30 to 50% of fetuses after termination. We must try to reach the chromosomal as well as molecular diagnosis all the fetuses, so that counseling and prenatal diagnosis in future pregnancies will be easier.
Right, sir. So thank you. And that is what every geneticist tells us, that please look at the babies who have been terminated. So I think a great message, because we need to take the pictures, we need to take the infantograms, we need to do the autopsy and do a molecular diagnosis. So let us try and preserve this DNA, save the DNA for this fetus, so that we have more information on that. So if Dr. Santosh is there, he can give his comment, or else we will just conclude this session. Dr. Santosh, are you there? Are you able to join? I don't think he's here right now. So I would just like to say that, this is just the beginning, and it's an island which is surrounded by a sea of mystery. And I think there cannot be a mystery bigger than managing congenital malformations for us fetal medicine specialists. So thank you all the panelists for their great contribution, and it's been a pleasure moderating this panel. Thank you everyone so much.
Thank you, ma'am. Thank you so much.
Thanks.
Thank you, Dr. Aparna. Thank you.
Dr. Aparna and all the panelists for the very well descriptive and very informative panel discussion. Moving on to the next and the last session for the evening, I would like to invite Dr. Ashok Khurana to present their talk on screening and predicting preeclampsia. Dr. Ashok, may I please request you to unmute your lines?
Yes, thank you.
Over to you, sir.
Thank you very much. And if I may be given a chance to share my screen, and while my screen gets shared, my congratulations to the Pune Obs and Gynae Society for putting together such a brilliant 29th meeting. COVID kept us away again in a situation that we couldn't help. But I think this has been brilliant, and my special thanks for them to them for involving the Society of Fetal Medicine in this workshop. It's been a very exciting workshop. My apologies for joining in late, but it's been a pleasure indeed, and we had a really eye-opening session on the cases. And I now will present the final session. Thank you so much for this invitation. It's been a truly fantastic event. I will discuss the prediction and ultrasound surveillance of preeclampsia, and take you through the state of the art today, and highlight how we are intelligently using the ISWOG practice guidelines for the screening and the follow-up, as well as the recommendations of the Fetal Medicine Foundation. And I will round it up with, at the end, with some of the recent advances that we can take care of, including how in resource-restricted situations we can get the best possible for our patients. So here we go. We do understand that preeclampsia is a disaster. We know that there's 10 million women all over the world that develop this in the course of a single year, and 76,000 women will die of complications of this disease. It's absolutely disastrous, and one of the major causes of maternal morbidity. Also, it's a disaster on the infant side, where we end up with so much iatrogenic deliveries, as well as then the consequent prematurity. And so we really needed to do something about this. And the good news is that for all that high-risk pockets that we have in India, where we have a reported incidence of as high as 27% in some areas, we are in a fair degree of a mess, which we're now coming out of. And we're coming out of it because we now have a first trimester method, which is an estimate to be given to the entire pregnant population in the first trimester, at a time when we can actually confirm that if they're screen negative, there's almost close to a 99% predictability that they will not get preeclampsia. Also, that we can give them low-dose aspirin before that 16 weeks window, and therefore we can prevent the severity of this disease and maybe prevent it altogether. We know that this low-dose aspirin is going to improve perinatal outcomes, and that if we add to this surveillance in later pregnancy, which we will also discuss today, we can actually improve the outcomes hugely, as has been proven in some validation studies already. The Indian scenario is equally disastrous, and 2 million women with preeclampsia annually and 380,000 with eclampsia, which is terrible. But again, we have things that we can use. So I'll take you through some of the basic sciences, and I promise you that'll be minimal. The methods of prediction of preeclampsia, which is the screening, but also a few lines on prevention, surveillance, of course, which we will go through in a lot of detail because it's relatively new, the screening in twin pregnancies, some newer approaches, and of course, screening in resource-restricted populations, which is so important for you and me today. So let's start right there at the beginning and say, okay, ultrasound is doing a lot in the first trimester, the 11 to 13 week 6-day windows, and you heard about this earlier this evening, but screening for preeclampsia really adds up to saving a lot more lives than any of the other things, simply because of the incidence. And the other great piece of news is something we learned from this publication in the American Journal of Obstetrics and Gynaecology last year, that we do so much of an effort for cervical cancer screening and mammograms, where the number needed to treat is so many compared to what we really need to do for preeclampsia. For instance, the number of pap smears we need to look at for cervical cancer screening and finding one positive is 1,140. And on the other hand, here, to look at the serious preeclampsias, we only need to screen 400 women. I mean, what a fantastic yield compared to the actual cost of screening and the social and the societal costs of this whole story. So it's something that we have to take forward because it is such an efficient process when done in the correct manner. It is important, of course, like for all screening, to understand that it's not foolproof, that we use it for the whole population, that most cases are likely to be identified, and that's the detection rate. And this has to be done as part of the pre-test counseling for all patients, just the same way as we do for, say, thalassemia counseling or Down syndrome counseling. That some cases will be missed, those will be false negatives, and the patient should be aware of that. And that does not mean that she can go dancing and not do anything that she feels like for the whole pregnancy and come back in the 9th month. Also, that some may never develop the disease and therefore we might be over-treating. But these numbers are so low, the false negatives and the false positive, that preeclampsia screening is now truly, truly worth it. We've had several models for the prediction, and the two big models are on the British side, the NICE guidelines, the NHS guidelines 2010, redone a few years ago, 2017, and the ACOG guidelines along with the American Society for Maternal Fetal Medicine, which add on high risk and moderate risk factors. And there's a few more factors added by the Americans because fortunately they do respect people who are Black and poor, which is nice compared to the British, who don't seem to think that is important. But the tragedy of all of this is that if we just look at these ACOG guidelines, the detection rate was ridiculous, 5%. I mean, you can predict more by tossing a coin. And look at the NICE guidelines, they're at best producing 39%. When we started with the FMF model of maternal characteristics plus uterine artery Doppler, mean arterial pressure, and PAPI and PLGF at 11 to 14 weeks, we realized that we've enhanced the 75% initially seen to almost 100% seen by the end of 2017. And that's where we stand today for the serious preeclampsia. It's also pretty good detection rate for all the preeclampsias all the way to to 37 weeks, where the detection rate is 80%. So obviously, this is the way forward, and this is certainly not the way forward. But we will discuss the gestosis aspect at the end of the talk, which is a low resource application. To understand what happens in preeclampsia and why we're making so much noise about it, we should understand that when the embryo burrows after attaching itself into the endometrium, and there is an invasion of these spiral arterioles by the syncytial trophoblast, and the first wave occurs by 8 to 10 weeks, and the second wave starts at 16 weeks, which is completed by 24 weeks, which is why we like to give in the aspirin before 16 weeks for best effects. And therefore, we expect improvement all the way up to 24 weeks. Ultimately, the entire endothelium will be replaced by syncytial trophoblast, and it will form vessels that are much less tightly coiled, vessels that are larger, and therefore able to convey as much blood that is required. When this gets conveyed, the fetus will grow right. There will not be physiological changes in the mother that will happen, or pre-existing changes that might become worse in the mother, as we know from the neo theories, but a more comfortable situation. Because it's very important to understand that following this abnormal trophoblastic invasion, for whatever reason, whether it's because the mother had bad physiology or because the placenta was the main problem, there is placental ischemia. When there is placental ischemia, we have endothelial activation, and this results in two things. One is vasoconstriction, which reduces the flow, and microthrombosis, which reduces the flow. And therefore, we have to relieve the vasoconstriction, the microthrombosis. And this helps us not only in preeclampsia. This kind of screening will actually identify placentas that can be treated to prevent growth restriction, abruption, HELP syndrome, and stillbirths as well. So we're looking at a much, much wider palette in case the process goes on smoothly. What's the equivalent that we look at? In the first stage, which is placental dysfunction, there is placental ischemia and oxidative stress within the placenta, and this results in a reduced uterine artery flow, a reduced PAPE, and a reduced PLGF. In the next stage, which will then happen therefore somewhere halfway through the mid-trimester, there would be vascular compromise when there is endothelial activation, and a protein called SFLT will go up, and the PLGF will go down, and if you happen to be doing the VEGF, which is not commercially available because it wasn't that great or wasn't that promoted, that will go down. And of course, then you have the florid syndrome with hypertension, proteinuria, liver dysfunction, and so on, when you have end organ damage. And what we try to catch it is at this stage and do a good amount of surveillance to catch this stage correctly so that we can prevent morbidity and mortality, both in the mother as well as in the infant. And so remember that we have this combination that we are going to use. This kind of a model where we're using biomarkers combined with maternal factors was what we used until very recently, and that's called a logistic regression model. That's a mathematical term. And I don't have time to explain that today, but the fact is it's a mathematical term. But although it gives a personalized risk, it fixes the gestational age cutoff for PE. It cannot be expanded to include additional biomarkers, and it does not take into account the increasing effect of biomarkers with the severity of the preeclampsia. And therefore, we've been on the lookout for a new model, and this is now available. And it's something that is being used more and more, and we will discuss this quite a bit. Because what we do in this is something called a competing risk approach. You change the inputs at the period in time in pregnancy, and you get a better prediction of disease in the next week, a better prediction of disease in the next 4 weeks, and the ability to exclude the likelihood of this disease in the coming week as well. So it's a great way to actually rule out complications and send this poor girl home instead of keeping her in hospital just for a surveillance. The advantage of this competing risk approach is that it gives a personalized risk, of course, but a preeclampsia at any desired gestation later in pregnancy that can be expanded to include additional biomarkers measured at any gestational age all the way up to term. It does take into account the increasing effect of biomarkers with the severity of PE, so it's truly magical, and it actually uses the original posterior risk and goes on to use each time another posterior risk and keeps adding up till you get some excellent prediction and you know exactly how to handle your patient. And to re-emphasize for you, and I'm saying this again and again, it always has 4 components, and don't forget that if you don't use all of them, you're actually compromising the results. So maternal characteristics with uterine artery Doppler, with mean arterial pressure and biochemistry, and you have the way to start this. For uterine artery Doppler, we start with obtaining a mid-sagittal section of the uterus and cervix. Most of this is done transabdominally. You then tilt the transducer sideways so the uterine arteries are identified. There's a high velocity flow, and you can see that. Then you set your gate, which is narrow, about 2 millimeters, and you position this on the ascending branch of the uterine artery, which is this one after it's given off the descending branch. And then make sure that the inclination angle is not more than 30 degrees. And to make sure that it's right, make sure that the peak systolic velocity should be greater than 60 centimeters per second. Otherwise, you may not be sampling the right vessel. And then when you get 3 nice identical waveforms, you then measure the PI. It's as simple as that. The vast majority of this is done with a transabdominal scan. Sometimes you might need to do a transvaginal scan, but remember that the uterine artery resistance is higher on transvaginal scans compared to transabdominal measurements, and therefore the 95th centile would be different. And the 95th centile is what we use as a cutoff to be able to identify an abnormal uterine artery, but we never use it alone by itself. Always in perspective, otherwise the predictability is not as great and the actual screening doesn't work so well. Remember also that if you have a heavier patient, and in certain FMA groups, you might also have a different uterine artery PI, but for now, we're not confusing the charts. We're using one standard chart that's available, and most of us use the FMF chart. Remember that we try and look for a high impedance flow velocity waveform, but we don't use pattern recognition because a notch in early diastole is fairly common at this stage of 11 to 14 weeks of gestation. And this business of your classical great amount of flow at the end of the cardiac cycle is something that may not be seen most of the time. So what do? You take the right uterine artery PI, you add it to the left uterine PI, and you divide it by 2. And this mathematical mean can then be read off the chart and put into your calculations. And that's all that the algorithm requires for a final calculation. There was always the situation, should I use RI, should I use SD ratio? No, we just use the PI. Why? Because it averages all the maximum velocities and is good representative. You need clean velocity waveform, but I don't see any problem in obtaining those. And also the PI is more stable and does not approach infinity when there is absent or reverse diastolic value. And that is a critical point where we want to know the PI, and therefore we use the PI. Do we use the notch? We've thrown the notch out of the window. There's all this stuff here in fine print, which tells us to throw the notch out of the window. We've used ASPRE studies, pre-study, this, that, and the other. We've used the Fetal Medicine Foundation bit, and we've thrown the notch out of the window. It makes no sense. It is statistically not significant. We don't talk about the notch in 2021. We've not been talking about the notch for several years now. But let's move on and say, okay, the next step would be mean arterial pressure. Remember, it's to be taken in both arms at the same time. The patient should be relaxed. In Western situations, women relax when they're left alone. In Indian situations, women relax the most when they're in company. So perhaps we can change that from the FMF consideration. But do remember, you have to choose the correct cuff size according to the mid-arm circumference. And therefore, you must realize that you should have the availability of cuffs that are small, medium, and large. In Northern India, of course, we seem to be using large most of the time, which also means that we have a lot more preeclampsia than anywhere else. The woman should be relaxed as much as she can, and we try and do this in a silent room and both at the same time, like I said. The BP recording should be done as per this. If you don't do that, it doesn't work out right. There is a complicated formula for calculating the mean arterial pressure, but we don't have to worry about it because what the algorithm really wants us to do is to just put in the diastolic BP, 2 readings, the systolic BP, 2 readings, right and left, and you have your answer, which is calculated automatically. So you don't have to sit and use this formula. It's done in the software for you. This is some of the older data, and this is some of the newer data. And we realize that since 2013, if we use the new FMF algorithm and use everything together, we get 100% detection rate of the serious preeclampsias with a false positive rate of 10%. I always get asked the question, should I use PLGF? Well, if you don't use PLGF, then you're not going to have such good a prediction. And if you don't use any biochemistry, you're not going to have such a good prediction. And therefore, it's very important. If you don't use the uterine artery, then you keep going backwards. And that's a bit of a disaster, and that's not so nice. So we can't afford to do that. If we use just the uterine artery PI and the PLGF, we still might be better off. But then where's the problem in anyway taking a mean arterial pressure? Yes, we might save some money by not doing a PAPE, but the commercial kits are such that the PAPE seems to be included anyway in the first trimester screen. Therefore, it seems to be wise to do all of it. So please do not put a question in the question box do I need to do PLGF? Of course, you need to do PLGF. It's available, and it's available as a package. And you know, we love packages in our part of the world, so why not just use the whole thing and hit the 100? And that's the way we'd like to do it. Yes, we're not so good at term preeclampsias, we're not so good at the late preeclampsias, but we're getting pretty good. We've reached 80 compared to a few years ago when we were not even reaching 40. So that way we're getting better and better. And then, of course, my emphasis that when we do this, the great thing is that if we treat this, the onset of preterm preeclampsia shifts all the way. So a 28 will hit you at 36 weeks. A 30-week disaster will only hit you much later down the line. And therefore, you're shifting that entire curve to a point where the baby has a better outcome because it's managed to grow more and better and has better maturity. And that is what determines outcome. Therefore, this is what we're aiming for. But to aim for that, you need to give the right dose of aspirin. Now, why don't we use 75 and 80 like the world seems to be using? The 75-80 is something based on aspirin resistance, that there would be systems that would be resistant to low-dose aspirin at 75 or 80 milligrams. The aspirin resistance in cardiac patients who need to take low-dose aspirin is not as bad as in pregnant patients. In pregnant patients, aspirin resistance is as high as 30 to 35%, and therefore, we definitely need to use the higher dose. A dose anything greater than 100 milligrams, and it's convenient to put it at 150. If you have a heavier patient, please calculate at 2.4 mg per kg and then work it out. And we've known this since 1979, but we seem to have lost it along the way. Let's make sure we remember this correctly. What about after 16 weeks? Some say yes, some say no, some say the data is robust. I personally feel that when we do start aspirin even later, there is this general improvement of maternal and fetal morbidity, not the mortality, not the really serious stuff, but the not so serious stuff can actually get reduced by 10%, so why not? The question is that yes, it's still a personal choice, may not be so scientific, but the actual dose of greater than 100 milligrams to be started at night is the right dose to start this with. Now, to come up with this chart, the Fetal Medicine Foundation has taken almost 2 decades, and here it is lying ready for us to use. And this teaches us how to move beyond the first trimester and realize what we have to do in the second and in the third trimester. We use mean arterial pressure at all points. We use uterine artery PI at all points except at term, because then it doesn't seem to contribute very much. It might contribute to the assessment for growth restriction, but it won't contribute to your assessment for preeclampsia. The PLGF is used at all times, and in the second trimester onwards, we add SFLT1. PLGF is an angiogenic protein, and a low PLGF is a reflection of placental dysfunction. And it correlates strongly with time to delivery in the suspected preterm preeclampsias. The other one, this SFLT, is actually a soluble FMS-like tyrosine kinase, SFLT1, and we utilize the ratio of both these factors, and there is a magic ratio we've come up with that less than 38 seems to be very comfortable, more than 85 correlates with severely poor preeclampsia outcomes, and 38 to 85 would be mild outcomes. And notice that the sensitivity of preeclampsia detection and surveillance and outcomes becomes much better as you go through that pregnancy, which is why we now use the competing risks model. Then, of course, we understand that we keep on referring to this 38 to 85 and greater than 85 thing, and let's see how we actually use this for the surveillance. We now know that VEGF is not commercially available, so we depend largely on PLGF and, of course, latent pregnancy on SFLT1. There is another one which may become available in the future, placental protein 13, but we'll tell you more about it as and when it comes. For now, we're using this. So let's move out of that initial screening first trimester to what do we do for preeclampsia screening in the second trimester. We need to do it in all those patients who've never had screening before. But we also need to do it in patients who've been screened before, but need a surveillance plan for the second and the third trimester. Now, we will remember again that here again in the second trimester, the transvaginal PIs are higher than transabdominal scan readings, and so you need to fix for those when you put in your readings. And if you have a largely left or right wall placenta, you might have a discrepant PI, But the mean PI is still to be used, and that's the way to truly go about this, that you use the mean PI, you use the mean PI, you use the mean PI, and you throw the notch out of the window. Yes, the notch will guide you to a bad PI in the second trimester, but we don't attach importance to the notch by itself. We actually use the calculated value of the PI. We then move on to a free FMF calculator, where after putting in the patient demographics, all you need to do is to put in the mean arterial pressure and the mean uterine artery PI, and then decide whether you have PLGF and SFLT levels. And you can write no, or you can say, okay, these are my MOMs, or you can even put in raw data of the actual value, and they will convert that for you. Make sure that everything in the demographics is ticked off, and then it gives you an answer. And this is how it works. This is a busy slide, but we'll take a few minutes to go through this slide and tell you how this works. Because when you use that calculator at 22 weeks of pregnancy or later, women get stratified into a high risk, an intermediate risk, and a low risk group, which require different management. The high risk group would require very close monitoring for high blood pressure and proteinuria between 24 weeks of pregnancy and 31 weeks of pregnancy. And depending on the clinical situation, it might be as frequently as every week. The intermediate risk group, together with all the undelivered pregnancies from the high risk group, would have reassessment for preeclampsia at 32 weeks. That means you will not touch them after 22 or 24 weeks. You will see them straight at 32 weeks. And that would require, and these would require close monitoring for blood pressure and proteinuria between 32 and 35 weeks. We then work on cutoffs. At a risk cutoff of 1 in 25 for preeclampsia less than 32 weeks, 1% of the population will be stratified into the high risk group. And this will contain nearly all those cases, I repeat, nearly all those cases that will develop preeclampsia at less than 32 weeks. And therefore, we will follow them closely from 24 weeks. So that cutoff is 1 in 25. If we use a cutoff of 1 in 150, and then we're looking at preeclampsia less than 36 weeks, that's how we look at it, then 10% of the population would be stratified into the intermediate risk group. And this will contain 9 out of 10 cases that will develop preeclampsia between 32 and 36 weeks. And all of these would then need reassessment at 32 weeks. So this is how it works: a high, an intermediate, and a low risk group. Now, all pregnancies, irrespective of their original risk, would need to be reassessed between 35 and 37 weeks to define the high risk group for term preeclampsia. So it's something that moves. It's something that is dynamic. It's not something that you do at one time. And all this information is available in a beautiful article that appeared in the White Journal in the early issues last year, about January, and was written by Leona Pune. And I will now discuss a few more things that she told us. But before we go to that, we also have some excellent information from the prognosis study, which talks about the time to delivery in third trimester preeclampsia. And it clearly told us that the addition of the SFLT-PLGF ratio measurement to the proteinuria assessment and blood pressure assessment can reduce hospitalization by as much as 50% and set these women on the right track instead of needing to keep them in hospital. And a very, very specific matter for knowing which ones are developing preeclampsia within 1 week, and not too bad also for 4 weeks. But look at the negative predictive value, a 98.9%, and in the validation cohort, 99%, to tell you that, look, this 38 is a fabulous way to decide which ones need to come in and which one can be safely sent home. This is the algorithm that Leona Pune has given us. And we start off with the usual screening that we talked about, and then we divide those on the basis of high risk or low risk. For the ones that have a low risk, you reassess them initially at the time of your anomaly scan, but definitely also at about 22 weeks, and then decide on the basis of that whether they have changed their actual risk. And in that case, then they would then move on to an intermediate or a high risk. For the high risk group, again, we will see all of them somewhere at that time and say, okay, you can then use one of two algorithms. You can either follow the second trimester FMF algorithm, or if you have an SFLT and PLGF measurement at 24 to 28 weeks, you can use this particular algorithm. And let's see how these work. The low risk out of the second trimester assessment can again go back to be seen at 35 weeks. The intermediate risk you will start seeing somewhere at about 32, or they say 30 to 34. And the high risk you start looking at from that 24-week scan onwards. If you have the biochemistry, then life becomes a lot easier, because the ones that are less than 38, back to standard surveillance. The ones between 38 and 85 would require increased surveillance, and the ones greater than 85 would really, really require very, very close surveillance, so that you don't lose the mother, you don't lose the baby, and you don't let the mother get too sick, and you don't let the babies get too sick. Remember that everyone but everyone will get reassessed at 36 weeks, or between 35 and 37, and get an answer. Again, this wonderful thing that if the SFLT PLGF ratio is greater than 38, progression within 4 weeks is likely, and if the SFLT PLGF ratio is less than or equal to 38, progression within 1 week is unlikely. So a great rule out tool and a fairly decent rule in tool as well. And like I said, this is a free download from the White Journal in the earlier part of last year. Twin pregnancies, yes, we have good news for twin pregnancies. We know that because of the increased placental mass in twin pregnancies, the uterine arteries are much better, and therefore we have to have twin-specific reference ranges for the uterine artery PI. The combined screening works, but almost 75% of twins will test screen positive. And then we say, well, then we don't really need to bother, because most of the twins are IVF, and most of them would actually then be on aspirin already. Well, but not all of them would have the same risk. Not all of them would be IVF, and the infertility group actually get only 75 milligrams of low-dose aspirin. And with my 33% resistance, I'm not going to take a chance on that. I need to heighten my surveillance, as well as I need to heighten and change my 75 milligram dose based on the 2.4 mg per kg, or at least 150 milligrams. And again, for twins, the minimum dose should be 100 milligrams of aspirin. Now, the next thing is, what do I do for resource-restricted countries? Two possibilities. We can follow the FIGO recommendations, which are attenuated from the FMF guidelines, which says that, look, uterine artery Doppler may be too expensive, biochemistry may be too expensive, but you can train your staff to do maternal characteristics. You can train your staff to do a decent mean arterial pressure. Albuminuria is not expensive, maternal weight is not expensive, edema assessment is not expensive, and depending on what you find, you refer to tertiary care or counseling, depending on the ability of your institution to handle it. So that is the FIGO recommendation for resource-restricted countries. In India, we've come up with a fantastic thing by the organization Gestosis, which gives you a Gestosis score. It has clinical criteria. The validation is awaited, but should be here soon. And this is what it looks like. You have a whole list of things. You mark them off and give them scores of 1, 1, 1, 1. Or on this side, as you can see, scores of 2, particularly for thrombophilias. You end up giving scores like 3. And gestation diabetes, give a score of 2. And you get a score. And then depending on this score, then you can, in a very inexpensive way, decide this. But remember, the sensitivity would never be the same as otherwise. And so you have to then counsel your patient that this is an institutional protocol, this is a national protocol, but it may not be the best detection protocol in the world. So then your patient can take that choice and see whether they want to add on the ultrasound and whether they wish to add on the biochemistry. So these are the options, like in any other counseling, that we have to let our patients know about. Is there something else we can do? Yes, a few more things before I close. And I promise I'll take only 3 or 4 minutes more. One is that we have something called Congo Red. And Congo Red is a misfolded protein, and it comes out in the urine of women who are prone to preeclampsia. And it's available as a kit. And the more Congo Red that binds to the misfolded proteins, the dye spreads more evenly. And therefore, this is something that you can read off by a comparative chart. It's something you can do on an OPD basis. It's likely to be inexpensive. It's undergoing validation studies pretty soon by a team led by Dr. Parna Sharma, who is doing it on behalf of the Society of Fetal Medicine. You heard her during the panel discussion before this, and it's something that we hope will be India's answer to women who just walk in at any time, particularly somewhere around the 5th or 6th month, and say, look, I've got swelling and I'm pregnant. And they've got no workup done before this. This is something that is the future of a country where healthcare continues to be disorganized for reasons of our planning in the last few years and for reasons of our general public mentality towards health in general. Do we have anything else? Yes, we've had this paper published by my group many, many years ago, and it went into the dustbin because I think it was a paper before its time, and it's been revived now because things have moved on. And we're happy about that because we were actually the first to come up and show that a 3D powered Doppler evaluation of the placenta at 11 to 14 weeks improves the prediction of all adverse outcomes, including preeclampsia, in patients with low PAPI levels. And we had specific settings for the 3D powered Doppler. And if you followed those settings, and irrespective of a big placenta, flat placenta, thick placenta, it still gave us great answers and continues to give us great answers. And we have to have a larger cohort soon. What else? What else is the addition recently of the ophthalmic artery Doppler that has been described by Kypros Nicolaitis. And he has shown us that if we place the transducer like so on the closed eyelid, we get this kind of a waveform, which has a peak systolic velocity, a dip, a second peak systolic velocity, a notch, and flow at the end of diastole. And what you have to do is that we don't use the first PSV, we don't use the second PSV PI, and we don't use the PI, we use a ratio of the second PSV divided by the first peak systolic velocity. You take 2 readings from each eye and you don't cut corners, and you get a really good amount of advantage of your screening. The technique is now well described. The mother's in the supine position. You use a high frequency linear transducer. You place it transversely over the upper eyelid and the eye is closed, and you use gel on it, and you can use standard gel, and you use color flow to identify the ophthalmic artery, and you'll be able to see the signal right from it. You have an angle of inclination less than 20 degrees, a sample gate of 2 millimeters. You use a depth of about 3 to 4.5. You use a high pass filter at about 50 hertz and a PRF of about 125 kilohertz or so. You can fine tune these, but remember that you use not your standard transducer, but a linear transducer. And this is how it works. If you add on the ophthalmic artery, and you know how inexpensive it is to add on the ophthalmic artery because people in radiology and imaging sell themselves quite cheap, if I may say so. At 19 to 23 weeks, it actually alters the detection rate of the predisposition to preterm preeclampsia from 56% using the older algorithm to 80% if you include the ophthalmic artery. Also, for preeclampsia beyond 37 weeks, it increases the detection rate. And this is when you start screening at 19 to 23 weeks. If you add on the ophthalmic artery later in pregnancy, and we now reached the 35 to 37 weeks window, we understand that the problem of spotting trouble in the next 3 weeks goes up from a detection rate of 31% without the ophthalmic artery to 69% if you include the ophthalmic artery. It takes a few seconds. It's not difficult. The learning curve is extremely steep. You learn it within a few cases, and it's easy to do. And remember, this is fresh out of the oven. These are papers from 2020 from the Kypros Nicolaitis group. And this is the way forward, particularly in a country like ours, where biochemistry tends to be expensive and ultrasound tends to be cheap. What else is new? Maternal cardiac function. It's on the horizon. It's been pushed by a very brilliant man called Baski Tiliganathan, who feels that the maternal heart is at the basis of all preeclampsia disease. And we're now trying to assess the degree of contractility of the maternal heart and see how that might predict the prediction or improve the prediction for preeclampsia, but more about this in the coming years. So at the moment, where do we stand? We use the FMF algorithm, maternal characteristics, uterine artery Doppler, mean arterial pressure, biochemistry, and remember that uterine artery Doppler alone is not as good as all factors together. That is something that we must understand. And thank you so much for your attention.
Thank you very much, Dr. Ashok, for walking us through this very informative topic. It was really amazing. Quickly checking with the audience, any questions for Dr. Ashok? So since we have 2 minutes, we can do a sort of quick Q&A in case there are any questions for Dr. Ashok.
Perhaps too late at night.
Yes. All right. So ladies and gentlemen, with this, we come to the end of day 1, 29th Annual POGS Conference Re-Edify 2021 at Virtual Fetal Medicine Workshop. Thank you for being an amazing audience, and we'll see you again tomorrow morning for the day 2. This is me, Diksha Raina, signing off for the day. Till then, keep smiling and stay healthy. Thank you.
Thank you very much.
Thank you. Thank you very much.
Thanks, everyone.